The Senate Committee on Health, Education, Labor, and Pensions will come to order. And let me begin by thanking the CEOs of Eli Lilly, Sanofi, and Novo Nordisk, the three major manufacturers of insulin, for being with us today, as well as the heads of CVS Caremark, Express Scripts, and Optum Rx, the three major pharmacy benefit managers. They had to juggle their schedules, and we very much appreciate all of them for being here. I also want to take this opportunity to thank Eli Lilly, Sanofi, and Novo Nordisk for, in recent months, as I think you all know, announcing a substantial reduction in their list prices for some of their insulin products, and this is an important step forward. For me, the bottom line of this hearing is not complicated. I don't care whether you're a Democrat, or Republican, Independent, or whatever you are, all over this country. People are saying enough is enough. They are sick and tired of paying outrageously high prices, not only for insulin, but for other products as well. They want action, and this committee is going to do what we can to respond to their needs, and we need the help of the people on the panel to do that. And as we gather today, and I know we have some advocates in the audience who have spent a great deal of time fighting to lower insulin costs, and we thank them for what they do, I think it's important that we acknowledge too many Americans who died because they rationed their insulins. 1.3 million Americans do that, and some of them died. Alex Smith was 24 years old, and he dreamed of opening a sports bar. He is dead because he could not afford insulin. Antavia Lee Warsham was 22 years old and worked 2 jobs to support herself. She is dead because she couldn't afford insulin. Alan Rivas was 20 years old and had already lost his home because of insulin cost. This young man is also dead. And these are just a few of many Americans who have needlessly lost their lives because of the outrageously high cost of insulin. Further, we must acknowledge the thousands of Americans who ended up in emergency rooms or hospital beds suffering from diabetic ketoacidosis, a very serious medical condition as a result of rationing their insulin. 1.3 million Americans in the richest country on earth cannot afford insulin. The committee today is convening for 2 major reasons, in my view, and one of them is a little bit personal. A couple of years ago, I took a trip from Detroit, Michigan to Windsor, Ontario, with a busload of people. You know why I went? Windsor is a beautiful town. That's not why I went. I went with those people in order to purchase insulin in Canada, which they were able to do for 1/10 of the price that they were paying in the United States of America. 1/10 of the price for the exact same product. And I'll never forget, as long as I live, the tears coming out of a mother's eyes because she could suddenly afford insulin. And what I promised them is that they're not going to have to go to Canada or other countries to buy a life-saving product, that in America we can make sure they get it here as well. And secondly, this committee is not only going to be dealing with the crisis in insulin, we're going to do everything we can to end the outrage in which the Americans, our people, pay by far the highest prices in the world for virtually every brand name prescription drug on the market, whether it is a drug for cancer, for heart disease, for asthma, whatever the illness, we end up paying the highest prices in the world. And we want to know why there are Americans who are dying or becoming much sicker than they should because they can't afford the medicine they need. Those are the questions that the members of our panel are going to have to answer today and in the future. Today, 1 out of 4 Americans cannot afford the medicine that their doctors prescribe. That is beyond comprehension. And let's be clear. The high cost of prescription drugs not only impacts the health of individual Americans, but the budget of the United States of America. If we paid the same prices for prescription drugs as major countries around the world were paying, we could save over $1 trillion in 10 years. I know many of my Republican friends concerned about the deficit. I share that concern. Pay the same price as people around the world, you save $1 trillion over 10 years. That's real money. And let's be clear, while Americans pay outrageously high prices for prescription drugs, the pharmaceutical industry and the PBMs make enormous profits every year. In 2021, 10 major pharmaceutical companies in America made over $100 billion in profits, and their CEOs get very high compensation packages. Last year, the 3 major PBMs in America made over $27 billion in profits. In other words, people in this country get sick, they can't afford the medicine, and yet the drug companies and the PBMs make huge profits. In terms of insulin, let us not forget that a vial of insulin, and this is a vial of Humalog right here, costs less than $10 to manufacture, as I understand it. Somebody will correct me if I'm wrong. I think it's less than $10. Meanwhile, Eli Lilly increased the price of Humalog 34 times since 1996, from $21 to $275. The same exact product, no changes at all. Why did they do it? Because they could, because nobody here has stopped them. They could charge any price they want, and they did it. But it's not just Eli Lilly. Novo Nordisk increased the price of Novolog 28 times, from $40 in 2001 to $289. And Sanofi, a company that increased the price of Lantus 28 times, from $35 in 2001 to $292. In every instance, it's the exact same product that cost rose astronomically. And let's be clear, this is a problem that is unique to the United States. In France, 20 years ago, the cost of Lantus was $40. Today, it is $24. Went down. This country, this price has soared. Meanwhile, as insulin manufacturers continue to increase prices, PBMs signed secret deals to increase their profits by putting insulin products on their formularies, not with the lowest list price, but the ones that gave PBMs the most generous rebates. The good news is that as a result of a lot of public pressure, we have recently seen the major drug companies substantially reduce their prices. And that is good news. Eli Lilly announced that it would reduce the price of Humalog by 70%. Novo Nordisk announced that it would reduce the price of Novolog by 75%. Sanofi announced that it would reduce the price of Lantus by 78%. It seems to me our job on this committee is twofold. First, we must make sure that these price reductions announced by the drug companies go into effect in a way that every American with diabetes gets the insulin that you need at an affordable price. And this committee intends to hold a hearing next year to make sure that that is in fact happening. In other words, we just don't want words, we want actions. But lowering the cost of insulin is only part of what we must accomplish. This committee must do everything possible to make sure that the American people no longer get ripped off by drug companies and PBMs. And we've got to ask some hard questions. If Eli Lilly can lower the price of Humalog by 70%, why is it still charging the American people about $200,000 for Cyramza, a drug that treats stomach cancer? $200,000, but that same drug is sold in Germany for just $54,000. Why is that? If Novo Nordisk can lower the price of Novolog by 75%, why is it still charging Americans with diabetes $12,000 for Ozempic when the exact same drug can be purchased for just $2,000 in Canada? If Sanofi can reduce the price of Lantus by 78%, why is it still charging cancer patients in America over $200,000 for Caprelsa, a drug that can be purchased in Japan for just $37,000? These are the questions that the American people are asking. They want to know why nearly half of all new drugs in America now cost over $150,000. Who can afford $150,000. What world are you living in? How does it happen that cancer drugs, which in some cases cost just a few dollars to manufacture, a few bucks to manufacture, you guys are selling for $100,000? Really? Really? Do we not have any consciences, any moral values? So we got a lot of work to do in this committee. And the bottom line is we appreciate the work being done on insulin. We thank all of the advocates out there for fighting, but we got to make sure that Americans can afford the price of prescription drugs. With that, let me introduce Senator Cassidy.
Thank you, Chair Sanders. You know, in a sense, this is a culmination of a portion of my life. I went to medical school in New Orleans, did my residency in Los Angeles, and then treated patients in Baton Rouge, each time in a hospital for the poorly insured or for the uninsured. And diabetes was a constant, but also the ability to afford the drug was a constant as well. And it's been interesting for me because I've seen the work that you've done, the technology that you, the drug companies, have put together that have made these medicines more convenient to take and have made it easier for the diabetic to manage her diabetes. So one, a tip of a hat to you. But on the other hand, the ability, as we all know, the ability to afford the insulin is equally important as to the innovation that may have occurred because obviously if you cannot afford the innovation, it is as if the innovation has never occurred. Now, 100 years ago, diabetes was a death sentence. In 1983, when I graduated from the medical school, a lot more difficult to control than now. Not only have we had the medical breakthrough, but we've had you come up with products that have made it easier for the diabetic to manage. I thank you for that. It goes without saying, in that time period, we've had a remarkable increase in the quality of life. That the teenager going to high school is much more managed, and therefore she's more likely to take her drug. And we all thank you for that. But one more time, you've got to be able to afford the innovation. So now we have to look, I think Senator Sanders framed it. The issue is it the pharmaceutical manufacturers? Is it the pharmacy benefit manufacturers? That's the kind of discussion here, and that's why I'm glad you're here. When I go to church and people are pulling on my jacket, they want to know about drug prices. And if they're diabetic, they want to know about, what about the price of prescription drugs? And if it's a parent of a diabetic, they're really pulling on my on my jacket. So the PBMs, vertically integrated with the largest insurance companies in the world, managing about 80% of the prescription drug claims. And I've learned to say what I've been told, not what I know. But what I'm told is that in recent years, the net price of insulin has actually decreased, even as the list price has increased. The money is going someplace, but the patient, particularly the patient who is in her deductible, is paying list price, and somehow the money is going from her pocket to folks who are far richer than she. Now, I appreciate the roles that pharmacy benefit managers play. We had some Zoom hearings with academics come in, and the academics all will state that at their best, PBMs drive down net price for patients. So I'll stipulate that. But it's clear that the savings are not always reaching the patient. And that at times, particularly when she's in her deductible, she's really paying a lot. And that's when we hear the horror stories of folks that cannot afford. So to have the manufacturers, to have the PBMs here is just really wonderful. The goal of today's hearing is to find answers and to find solutions. Not to point fingers, although there'll be some finger pointing, it is Washington, D.C. But on the other hand, to figure out what is going on. And to address why are prescription drug costs so high, particularly for the issue of insulin, and what is the respective role of each of the players. I suspect that if we realign incentives, we can actually find a way to benefit patients. I've learned since graduating from med school way back in '83, that oftentimes bad behavior is driven more by bad incentives than by bad actors. So what can we do about those incentives? Tomorrow, we'll continue our markup on bills addressing PBMs and generic drugs. The goal of is to try and make sure that everybody has access to these drugs and that they can afford it. But today is our opportunity to inform our legislation. So I'm committed to working with my colleagues to find common ground on solutions that fulfill our objectives, and by the way, the President will sign into law and that the House of Representatives will pass. This should be our goal. Once more, I thank you for being here. I look forward to your testimony as to how you propose we can lower costs for American families. With that, I yield.
Senator Cassidy, thank you very much. Our first witness is Mr. David Ricks. He's the Chair and Chief Executive Officer of Eli Lilly. Senator Braun, as I understand it, wanted to introduce Mr. Ricks because he is from Indiana, where Eli Lilly is located. Senator Braun.
Thank you, Mr. Chairman. Ranking Member Cassidy, yes, I'd like to introduce Mr. David Ricks, fellow Hoosier, CEO of Eli Lilly and Company. Indiana is a place of a lot of companies that have loomed large, not only in pharmaceuticals, we're the biggest manufacturing state per capita in the nation. With experience ranging from sales to drug development, Mr. Ricks has served in a variety of domestic and global leadership roles with Lilly, most recently becoming its CEO in 2017. Eli Lilly was the first pharmaceutical manufacturer to commercially produce insulin and currently markets several forms of insulin. Thank you so much for agreeing to be here in person to not only discuss your products, but you and I have had many discussions on what ails the industry in general, from hospitals to insurance companies to pharmacy, PBMs within it, even practitioners. A big lack of transparency, inherent competition that drives most other industries. So thank you for being willing here today to answer some of those questions.
Mr. Ricks, you're recognized. Thank you.
Thank you, Chairman Sanders. Thank you, Senator Braun, for that introduction. Ranking Member Cassidy and distinguished members of today's committee, I'm pleased to be here to participate in this hearing. My name is Dave Ricks. I'm the Chairman and CEO of Eli
Ricks,
Lilly.
can you hold that mic a little
Sorry.
bit closer to your mouth, please?
I'm the Chairman and CEO of Eli Lilly and Company. I joined Lilly, an American company headquartered in Indiana, 26 years ago because I believed in our mission. Innovation is at the heart of what we do, particularly for people with diabetes. As has been said, in 1920, type 1 diabetes was essentially a death sentence. The first animal-derived insulins, which Lilly introduced, extended life expectancy to a person's 30s. Today, after a century of innovation, life expectancy is now well into a person's 60s. But we're not done. Diabetes still significantly reduces people's life expectancies. And even with modern insulins and devices, 2/3 of people struggle to keep their disease under control. So there's more work to do, not only on diabetes, but on cancer and on Alzheimer's and other serious conditions. That's why Lilly invests 25% of our total revenue, this year $8.5 billion, into R&D. That enables us to introduce new medicines, 19 in the last decade alone, including the world's first monoclonal antibody for COVID, and many more medicines coming in the pipeline. In fact, just last week, we shared exciting results from a new study studying one of our medicines in Alzheimer's disease, which followed billions of dollars in investment, literally decades of work, and several failures that preceded it. Of course, medicines do no good if people can't afford them and access them. That's why I'm proud that we've led the industry in making insulin more affordable. Our efforts have driven what people pay for a month's supply of Lilly's insulin down to $20.48 per month, about 75 cents a day. And that was before our recent announcements, which will drive those averages even lower. We began these efforts years ago. Lilly hasn't raised the list price of any Lilly insulin since 2017, the year I became CEO. We've only cut them. In 2016, we launched Basaglar, the first follow-on biologic insulin in the United States, at a discount to the original brand. In 2019, we launched Lispro, brought a box of it here with me today, a non-branded copy of our leading selling Humalog at a 50% discount. We cut that price to 70%, and then May 1st, it's now $25 a vial. And when the insurance system was not working for some people who need insulin, we were the first company to cap their out-of-pocket cost at $35 per month, now automatic wherever technologically possible. And I believe we're still the only company that will cap all of our insulins at $35 per month. These efforts have saved people with diabetes last year $185 million, and year-to-date about 100,000 people per month, saving about $20 million for those 100,000 people. We've led the way on affordability against the headwinds of a healthcare system that unfortunately can incentivize others to prefer higher list price medicines. Higher list prices allow for higher fees and rebates, which can increase patients' out-of-pocket costs while benefiting employers, insurance companies, and people who don't use medicines. Lilly's Lispro is just one of many examples. Even though it's identical to Humalog and costs 70% less, I've brought boxes of both here, only 1 in 3 people today in the United States have access to the lower priced Lispro, and a preference for higher prices over a lower priced product that's identical should never happen. The list prices for insulin over time gets a lot of attention, but even before our recently announced price decreases, our net price of Humalog, what we take home after rebates and discounts, was about the same as when we launched in 1996, accounting for inflation. Last year, about 80% of our list prices went to pay ever-increasing fees and rebates to companies who don't invent, didn't develop, nor manufacture the medicine. With the remaining 20%, we cover the cost of making and distributing the product, which also supports about 4,000 high-paying manufacturing jobs here in America with full benefits and pensions. We finance our patient affordability commitments and also contribute 25% of that net revenue back into R&D for newer and better medicines, including insulin. So reforms are needed. We need a system that supports both world-leading innovation and lower out-of-pocket costs for Americans. Those reforms must help patients at the pharmacy counter while also incentivizing U.S. companies to continue investing in world-leading amounts of R&D, which results in Americans having access to more and newer medications than any other country in the world. We're ready to continue to do our part at Lilly, and we're confident policy solutions are both simple and achievable. Thanks for having me today.
Mr. Ricks, thank you very much. Our next witness is Mr. Paul Hudson, who's the Chief Executive Officer of Sanofi. Mr. Hudson, thanks for being with us.
Chairman Sanders, Ranking Member Cassidy, members of the committee, thank you for the opportunity to be here today. I'm here to talk about what I hope is our shared goal, to deepen our understanding about how the healthcare system works and what can be done to improve it for patients. It's also an opportunity to dispel some misconceptions. For example, insulin is sometimes described as a 100-year-old drug. But much like the cars bear little resemblance to the Model T, today's insulins are the result of years of research that have delivered significant improvements to patient outcomes and quality of life. At Sanofi, delivering transformative medicines for patients is our strategic imperative, and it's a role that we in the innovative biopharmaceutical industry uniquely play for society. Shortly after I arrived at Sanofi, I committed to refocus our research and development on medicines with the potential to deliver first-in-class and best-in-class treatments across areas of unmet need. Today, I'm very proud of the progress we made in support of these goals. Earlier this year, we announced positive results from a phase 3 study in COPD, the third leading cause of death worldwide. If approved, this medicine will be the first innovation for patients suffering from this disease in over a decade. This fall, we anticipate the approval for the first immunization against RSV disease for all infants. With this immunization, the burden of RSV on providers and its toll on families may never happen again. Finally, we also recently launched Tzield, the first medicine proven to delay the onset of type 1 diabetes. Over the next 15 months, we will learn the results of another 36 clinical studies, each with the potential to become a first or best-in-class medicine or vaccine. But these advances mean nothing if patients can't get the medicines they need. This is why I'm equally proud of Sanofi's long-standing commitment to affordability. We are transparent about our approach to pricing, including limiting our price increases, making medicines affordable through our patient assistance programs, such as capping out-of-pocket costs on insulin at $35 for the uninsured, and launching low-price versions of our insulins. We recently announced our decision to reduce the list price of Lantus by 78%. This was not the first time we've offered a low-price medicine to the system. Unfortunately, each time these medicines have received very limited coverage, resulting in limited benefits to patients, because the system is largely driven by the financial structure that links rebates and fees to the list price. For all the focus on the price of insulin, The list price is not the amount the system pays. In 2022, 84% of our gross insulin sales were returned to the system as rebates and fees. 84 cents on the dollar. In fact, since 2012, the average price of Lantus for commercial insurance and Medicare Part D plans has dropped by over 50%. Yet out-of-pocket costs for people in these plans has increased by 45%. Today, the average amount the system pays for Lantus is lower than it was when it launched in 2001. Simply stated, while competition is working to drive down insulin prices for the system, those savings aren't reaching many patients. Why aren't patients benefiting from the lower prices at the pharmacy counter? Well, today there are just 3 players in the system that cover 80% of American lives. These consolidated entities encompass pharmacy benefit management, health insurance, specialty pharmacies, and group purchasing organizations. This vertical integration gives these corporations near total control over the products that patients can access and the price they have to pay. And each of these integrated entities benefits from the selection of high-priced products on formularies because the rebates and fees they receive are calculated as a percentage of the list price. I know the committee is actively looking at solutions. We welcome changes that will make the system work better for patients while protecting the innovation ecosystem that allows new miracles to be developed and delivered to patients. We've contributed in the past, and we're willing to do so again. It starts with a holistic approach that fixes the misaligned incentives that drive the system's preference for high list prices, specifically delinking fees from the list price and requiring rebates to be used to lower prescription drug costs for patients at the pharmacy. Otherwise, I simply worry that policy reforms will do little to help patients. Thank you again. I look forward to answering your questions.
Mr. Hudson, thank you very much. Our next witness is Mr. Lars Göransson, who is the president and CEO of Novo Nordisk. He is going to be speaking to us virtually from, I'm not sure, Denmark. Is that where you are now? Yes. All right. Thank you very much, Mr. Göransson, for being with us.
Chairman Sanders, Ranking Member Cassidy, and members of the committee, thank you for the opportunity to speak today on behalf of Novo Nordisk. Our mission is to pioneer scientific breakthroughs and ultimately cure the diseases we research. We share the committee's concern that too many people fall through the cracks of the US healthcare system. We hope today's conversation will lead to meaningful action. I'd like to begin by briefly introducing myself. I grew up in a small rural town in Denmark. My sisters and I helped our parents to run the family farm. That early experience taught me to take responsibility and to work hard, not only for myself, but also for others. I joined Novo Nordisk almost 32 years ago and went on to work for the company in the Netherlands, the US, and Japan before I returned to headquarters in 2004. By then, my father had been diagnosed with diabetes, so I know the disease both professionally and personally. I am humbled to serve as CEO of a company that always keeps the patient at the center of everything we do. Our company was born out of a love story between 2 Danish scientists, August and Marie Krogh. When Marie developed diabetes, the couple embarked on a path to find a cure. This journey is where Novo Nordisk's commitment to treat and defeat diabetes began. Today, Novo Nordisk employs more than 55,000 colleagues worldwide. It is not well known, but our majority shareholder is the Novo Nordisk Foundation. Just last year, the foundation awarded almost $1 billion worldwide. Some of these projects support research partnerships between industry and academia here in the United States, while others focus on cutting-edge innovations around quantum computing and drug-resistant bacteria. We're proud of our company's financial success and that it fuels the foundation's work. As we have worked to treat and cure diabetes for over a century, I would like to address an often repeated misconception that insulin is still the same as it was back in 1921. Nothing could be further from the truth. 100 years ago, patients were supplied with a large reusable needle, glass syringes, and a whetstone to keep the needle sharp. They boiled the needle between uses, and insulin had to be injected repeatedly throughout the day and night. Early insulin saved lives, but it was difficult to use and came with serious risks. While advancements in insulin may seem minor or insignificant to those of us who do not have diabetes, patients tell us how our innovation have meaningfully improved their lives. We also know that no matter how pioneering a drug might be, it can only help patients when it is accessible and affordable. No one who needs insulin should have to ration or go without it because they cannot afford it. That should never be the case. Novo Nordisk has worked hard to fill the gaps of the US healthcare system, but we know the problem remains. That's why we are all here today. Patients too often find themselves trapped by a healthcare system with a misaligned economic set of incentives. It's a system where more and more dollars flow to insurers, the newly created subsidiaries, so-called group purchasing organizations, and the PBMs, but not to patients. We now pay on average 75 cents of every dollar of medicine we sell. And this money goes back to the middlemen to ensure that our medicines remain available to patients. Every day we ask ourselves, what more can we do for patients? What we can do is to try to fill the gaps for those the system has left behind. For example, we provide an immediate one-time supply of free insulin to any patient who faces rationing. We provide a long-term supply at no cost for Americans in need whose household make less than 400% of the poverty line. That's $120,000 for a family of four. And we supply insulin for patients through Walmart and other pharmacies that is sold for $25 for one vial. We work hard to ensure our affordability programs help as many patients as possible. We would like to do more and work with you today. Now is the time for all participants in the healthcare system to work for solutions that put patients first. I look forward to your questions. Thank you for listening to me.
Mr. Jorgensen, thank you very much. We've heard from representatives of the three major drug companies. Now we're going to hear from representatives of the three major PBMs. And our next witness is Mr. David Joyner. He is the Executive Vice President and President of Pharmacy Services for CVS Health. Mr. Joyner, thanks very much for being with us.
All right. Thank you, Chairman Sanders, Ranking Member Cassidy, and members of the committee. Thank you for the opportunity to discuss our work. Thank you for the opportunity to discuss the work we make healthcare more affordable, accessible, and ultimately to improve the health outcomes in this country. Our goal as the PBM is to remove as many drug pricing challenges as possible for our clients and their members. When people can afford their medications, like insulin, they are more likely to adhere to the prescribed therapies. Adherence means better outcomes. Better outcomes means the healthcare system will spend far less on complications and hospitalizations. In order to make medications more affordable, our job at CVS Caremark is to go head-to-head with the drug manufacturers to negotiate the lowest possible prices. The last 2 years have been challenging for millions of Americans as inflation surged and strained household budgets. A recent 2023 study by the IQVIA Institute examining drug costs found over the last 5 years, list prices have increased at a rate of 7.4%. Over the same time period, the PBM industry has helped clients hold increased spending to just 4.5% and kept member cost growth to just 1.4%. Specifically for CVS Caremark, clients, and for the 6th consecutive year, we have reduced patient costs at the pharmacy counter with an average member out-of-pocket cost below $9 for a 30-day supply. Today, it's important to note that more than 90% of all prescriptions dispensed are generic, and they represent just a little bit more than 18% of the total spend. By using competition in the generic categories, generic prices have been deflationary over the last decade. So now we are securing affordability for the final 10% of the name brand drugs, and that is our focus. Competition in the branded marketplace is critical, and we use this competition to deliver discounts to our customers. By negotiating rebates and discounts, we lower costs for our clients and their members where competition exists. Not surprisingly, many drugs without competition are the high-list price medications without discounts and account for much of our client spending today. We encourage the committee to focus its efforts here and we support the 3 bills addressing competition that the committee will consider in its markup. So drug manufacturers claim rebates are the reason for price increases, but the facts show otherwise. Government study after government study has concluded that price increases are not the result of rebates or discounts. Now, we also understand there are questions about the level of transparency we provide to our clients. The trust of our clients is critically important to us, and the trust is built on this transparency. Transparency starts at the beginning of our client contracting process and is a cornerstone of our approach throughout. Using sophisticated third-party consultants, clients negotiate transparent contracts in granular detail and understand how their healthcare dollars are spent. We have always prioritized bringing transparent offerings to the marketplace, and today we pass more than 98% of all the rebates back to our clients. We also provide them with regular detailed updates on drug spending and utilization, prescription claims processed, cost savings achieved, and also the manufacturer rebates that we receive. Our clients choose how to use those discounts or rebates by either reducing the out-of-pocket cost and or delivering lower overall premiums at the point of sale for the medications. I begin by highlighting the importance of adherence in reducing complications and hospitalizations. That is why we create and maintain preventative drug lists. This allows our clients to offer members $0 copays, including for insulin to treat diabetes and many other medications that are actually treating chronic conditions outside of the deductible. At CVS Health, we use this program to help our 200,000 employees stay healthy. We've made tremendous progress on insulin affordability through negotiations by inducing competition and encouraging clients to adopt plan designs that lower the out-of-pocket costs for their members. We have reduced the insulin cost on average 7% per year for the last 5 years. And our clients and plan members paid 1/3 less on average for a 30-day supply of insulin in 2022 than they did in 2017. At CVS Caremark, the average member cost for a 30-day supply of insulin was less than $25. And for those using the preventative drug list, again, it's $0. We also launched Reduced Rx, a program for the uninsured and underinsured patients with high out-of-pocket costs, providing insulin at just $25 per vial. We proudly provide pharmacy benefits to over 110 million people and improving their health every day. And we will continue to improve and innovate on our model and help clients provide affordable coverage for the medications their members need to stay healthy. I look forward to answering your questions.
Mr. Joyner, thank you very much. Our next witness is Dr. Adam Kautzner, President of Express Scripts. Dr. Kautzner, thanks for being with us.
Chairman Sanders, Ranking Member Cassidy, and members of the committee, thank you for inviting me to testify today. My name is Adam Kautzner. I grew up in rural Missouri outside of St. Louis and began my career as a pharmacist in a regional hospital. After working in nuclear pharmacy, I began my career at Express Scripts just over 15 years ago. I'm proud of our work to deliver affordable access to life-saving medications. This cause is personal to me. I was diagnosed with stage 4 melanoma in my early 30s. That experience strongly shaped how I approach our work to advance pharmacy care and lower prescription drug costs for patients and employers. As a business leader, I am guided by my experiences as a father, cancer survivor, rural American, and a pharmacist. Express Scripts believes all patients should have access to the medications they need at affordable prices. For decades, we've taken on one of the toughest challenges, negotiating with pharmaceutical manufacturers to lower costs for employers, health plans, federal and state governments, and most importantly, patients. We exist to help solve the challenges you are exploring here today. Our company has been at the forefront of introducing solutions to address the insulin crisis. In 2019, we launched a program capping patient costs for insulin to $25 or less. And these life-saving medications also have been extended for additional savings for cardiovascular diseases as well. We are constantly evolving and improving our services. This includes working to shield patients from exposure to high list prices at the pharmacy counter, to shield our clients from exposure to crippling drug costs, and to provide multiple transparent contracting options, ensuring our clients have complete control and flexibility to choose their benefit design, network, and pricing structure, and are provided robust financial disclosures. Our solutions for driving lower drug spending for patients and the broader healthcare system are working. Each year, Express Scripts saves more than $30 billion for employers, the public sector, and the patients we serve. This is driven by effective drug negotiation to medical management and to targeted clinical support programs. The savings are passed on to our clients at their direction, which benefits Americans in the form of lower premiums, reduced out-of-pocket costs, and expanded coverage. In 2022, savings negotiated by Express Scripts helped keep out-of-pocket average costs to less than $15 in the commercial market, less than $18 for patients using high-deductible health plans, less than $9 in Medicare, and less than $1 in Medicaid. None of this means the system cannot be improved. Drug manufacturers seek the highest price point possible and exploit the patent system and marketing practices to maintain monopoly status for their brands. For employers sponsoring high-deductible health plans, restrictions prevent lowering costs for patients before meeting their deductible. Rebates have been characterized by some as the mechanism for increasing list prices and thus increasing costs for patients. This claim is false. Rebates are discounts we negotiate to lower prices. More than 95% of our rebates are passed to Express Scripts clients, which benefits Americans in the form of lower premiums, reduced out-of-pocket costs, and expanded coverage. Without the ability to use this negotiating tool to achieve lower drug costs, healthcare spending would be much higher. Drug competition is ultimately what drives rebates, lower list prices, and lower net costs. We applaud recent efforts in Congress to speed the availability of generics and biosimilars and address abuses of the patent system that work to delay competition and maintain high drug prices. We recognize there are questions regarding the transparency and availability of pharmacy benefit services. Express Scripts is committed to being transparent to our clients and our beneficiaries. We provide robust disclosures which include principal revenue sources and information on rebate arrangements, fees, and pharmacy claims. We strongly caution against prohibiting contracting options entirely. These are options, not mandates within contracts, that are serving many of our clients today. Overall, our beliefs, our business model, and our orientation is geared toward 1, providing innovative solutions that enable access to medications at affordable costs with improved health outcomes. 2, providing clients with choices to enable them to deliver accessible, affordable pharmacy benefits. And 3, by providing additional levels of transparency about the value we create. Express Scripts will continue innovating to address drug pricing challenges and to respond to the needs of patients. I appreciate this opportunity to address the important questions raised about our role and how the value we create reaches patients. I look forward to your questions. Thank you.
Dr. Counselor, thank you very much. Our final witness is Ms. Heather Cianfrocco, who is the Chief Executive Officer of Optum Rx. Ms. Cianfrocco, thanks very much for being with us.
Chairman Sanders, Ranking Member Cassidy, and members of the committee, good afternoon. Optum Rx, a part of United Health Group, provides essential services to our customers, which include employers, unions, health plans, and governments. Our team works every day to make prescription drugs more affordable and to improve health outcomes for people. We do this by conducting evidence-based clinical review of medications, negotiating with manufacturers and pharmacies to bring down the cost of drugs, providing tools to help consumers and their providers use their benefits and find the lowest cost options, supporting patients with medication adherence and disease management programs, and serving patients in our pharmacies. Our customers pay for the medical and pharmacy care for their employees and their members. They count on us to be a counterweight to the substantial market power of manufacturers, which have the sole discretion in setting and raising prices for their products. We are held accountable for consistently delivering savings on prescription drugs, for lowering overall healthcare costs, and ensuring people have access to the medications they need. Overall, we deliver on average $1,600 in annual drug savings per person to our customers. 98% of our negotiated discounts pass directly to our customers, and they use these discounts to help reduce premiums, to provide point-of-sale savings, and to invest in health and wellness programs. Without our negotiations with manufacturers, the cost of drugs would be even higher. PBM saved the system $145 billion annually. People need consistent, affordable access to insulin. In the century since insulin was discovered, it has saved and improved countless lives. But over the last decade, manufacturers' list prices for insulin have nearly doubled. Along with leadership from Congress and others, our company has been at the forefront of efforts to make insulin more affordable. We began offering point-of-sale discounts on insulin and other rebated drugs to fully insured group customers in 2018. Since 2019, the number of consumers we serve who pay $35 or less per month for insulin has increased by 34%. Millions of people now have access to insulins at reduced cost through our preventive drug list. The 8 million people in United Healthcare, standard fully insured group plans, now pay nothing out of pocket for preferred short and long-acting insulins and other life-saving drugs, which includes EpiPens and albuterol. And working with Sanofi, we offer a monthly supply of insulin for $35 for uninsured individuals. The standard offering we recommend to our customers caps insulin out of pocket at $35 and supports affordability for patients in high-deductible health plans. And as a result, our 1.7 million consumers who take insulin now pay an average of $22 per month, and our efforts are ongoing. We also welcome the recent announcement by the 3 largest insulin manufacturers to lower their list prices on some insulin products. And let me be clear, we support and encourage lower list prices across the board. Despite the recent progress on insulin, more can be done. Cost sharing on a month's supply of insulin is now capped at $35 in Medicare. A similar approach in the commercial market would close the gap for Americans who still cannot consistently afford insulin. But importantly, such a cap must preserve the ability of PBMs to negotiate for lowest costs of insulin for their customers. Because even with the welcomed list price reductions by some manufacturers on some insulins, the list price of insulin is still above $35 per prescription. Beyond insulin, broader reforms are needed to foster competition among manufacturers and to make prescription drugs more affordable for Americans and sustainable for our country. Reforms are needed to promote access to generics and biosimilars, including closing loopholes that enable pay for delay, product hopping, and other delay tactics. A 10-year cap on a product's exclusivity should be established, regardless of the number of follow-on patents. And public policy should also support more value-based arrangements to ensure that resources are focused on the treatments that deliver the best outcome for patients. We appreciate this opportunity to share our perspective with the committee. Our company will continue to do our part to make insulin and all prescription drugs more affordable and to improve the health for all Americans. I welcome any questions you may have. Thank you.
Ms. Gianfranco, thank you very much. We're now going to begin questionings, and I'll begin it. And let me start off by saying, if somebody in the real world is watching this hearing, they've heard every single person from the drug companies and from the PBM say, we are working tirelessly to lower the cost of prescription drugs, just knocking our brains out. And yet, at the end of the day, 1.3 million Americans are rationing their insulin. People have died, people end up in the hospital. And you're all working night and day to lower the cost. And all over the world, people are paying a fraction of the price, not only for insulin, but for other products, drugs, than we are paying. So I'm going to, and I would appreciate very brief answers because we don't have a whole lot of time up here. So let me start off with Eli Lilly, and I'm going to go down the line here. Mr. Ricks, since 1996, Eli Lilly increased the price of Humalog 34 times, from $21 to $275, same exact product. I am told that it cost $5 to manufacture this product. And the story is not different for the products produced by Novo and Sanofi. So my question to you and to the other drug companies, will you commit to this committee today that you will not increase the price of any insulin product again? Mr. Ricks?
Thank you, Chairman, for the question. As I mentioned in my comments, all we've done
Brief,
is reduce
please.
the prices since I've been CEO. So I'm comfortable saying we'll leave our prices as they are for the insulins on the market today.
All of your products?
Yeah, in fact, we've been cutting them is the point I'm making.
You're not going to, Mr. Hudson?
We've said before, we have a responsible and sustainable pricing approach. We've had it since 2017. Net prices continue to fall, and the net price for insulin today for Lantus is lower than it was when it was launched in 2001.
So I'm hearing from you that you will not increase the price of any insulin product again?
To repeat myself, we have a responsible pricing policy, the standard in the
Yes or
industry.
no would be the better answer.
We have a responsible pricing policy. We've set that since 2017.
All right. Mr. Jorensen.
Yes, so thank you, Senator. We are committed to limit potential list price increases to single digit. We have not taken any for the past many years. In fact, we see double-digit decline in the price we get for our insulins for the past 6 years. And our net price today is lower than when we launched our products. So we see a dramatic falling price for our insulins in the U.S. market.
Okay. Let me ask the drug companies another question before I get to the PBMs. And that is, there are a number of newer insulin products that all three of you have brought forth to the market. All of these insulin products still cost more than $300. Will you commit to doing to those products what you've done to your other insulin products and substantially reduce the price of all insulin products? Will you make that commitment to us?
Senator, we've capped the cost to the consumer at $35 for every Lilly insulin.
So that means, I may be mispronouncing it, Liumjev, how do you pronounce that?
Lumjev.
Liumjev, wasn't close. All right. That's going to be sold for $35?
The patient will pay no more than $35 in the United States for that product.
Okay. Mr. Hudson, your product is Toujeo, is that what it is?
Yeah, and it's equal for us that it would be less than $35. If I could just add one quick thing, our most recent launch was Lantus at 60% lower list price that was not accepted by the system.
Okay. And the Fiasp is sold by Novo Nordisk. Mr. Jorensen?
Yes, and I can also confirm that we have availability of insulin that is below $35 for all of our insulins for patients if they want that support from us.
All right, thank you. Let me ask the PBMs a question. It's a simple question, and I would appreciate a yes or no answer. Will you commit today that your companies will put insulin products on your formularies with the lowest list price? Mr. Joyner?
We will commit to put the lowest cost product on our formulary, net of discounts and rebates. So whether it be the low list price or the high list price, our job is to deliver the lowest net cost, post-discounts, discounts off of high and or low list price.
Dr. Kautzner?
Thank you for the question, Senator Sanders. We will commit to putting the lowest net cost product on formularies. However, we also have of other formularies that are other choices for our employers to choose from, which do have low list price products also available. So we offer multiple different choices to our employers.
Ms. Cianfrocco?
We commit to always providing the lowest cost option to our clients, so the lowest cost. And other products are available to other clients through other formularies.
Thank you. All right, let me go back to Mr. Ricks. Mr. Ricks, Eli Lilly charges $196,000 in the United States for Cyramza, a stomach cancer drug. That same drug can be purchased in Germany for just $54,000. Will you commit to this committee to lower the price of Cyramza in the United States to the same price that you're selling it in Germany, $54,000? Yes? No?
Respectfully, Senator, that product has been on the market for a while. We do expect biosimilar entry. That's the primary mechanism in the U.S. where the price will fall. When that occurs, I'm sure there'll be competition in the price.
So what you're telling me is that the American people will have to pay 4 times more than Germans do for the same product that you manufacture. Okay. Mr. Hudson, Sanofi is a French company. In France, Sanofi sells a thyroid cancer treatment, Capelsa, for $30,000 a year. Sanofi sells the same drug in the United States for $203,000 a year. It's 9 times as much. Will you commit to lowering the price of Capella in the United States to $30,000, same price as it's sold in France?
Over time, with the introduction of competition and other biosimilars, et cetera, you'll see the price fall.
Yeah, so the answer is no. Mr. Urenson,
Mr. Chairman?
Yeah.
I hate to interrupt, but we are now, you're at 7 minutes.
you'll have the same amount of time, Senator.
Does every member have that?
Absolutely. All right, thank you. Mr. Urenson, in Denmark, Novo Nordisk sells a diabetes treatment, Ozempic, for $2,000 per year. That's 6 times more. You charge 6 times more to Americans. Will you reduce the cost of Ozempic in the United States to what it is in Denmark?
Senator, I believe the amount you mentioned for the US is before rebates. So on average, we pay 75% in rebates in the US. And for Ozempic, we actually see a price going down, our net price going down year over year. So we get a lower price already.
Answer is no.
I defer to Senator Paul.
The great thing about capitalism is that supply and demand intersect, and you get the largest supply at the least cost when you allow capitalism to function. Now, capitalism doesn't function very well in the drug markets because the government's been involved for a long time. But prices need to be based on supply and demand. A publicly traded company to promise to base their prices on bullying from a politician would actually be in breach of their fiduciary duty. I mean, it's actually illegal to say, oh, I'm going to make all the prices go down in my company, but it would also be irrational because if you did and there were no profit margin, the companies would be gone and they would no longer exist. Mr. Ricks, if a patient has a copay of $50, would the rational decision be then to choose Lispro over Humalog?
In the case where they were buying 1 unit, yes, they'd pay $25, not $50.
Right. So if the patient had a copay of $25 and Lispro is $25 and Humalog's $100, but I'm only going to pay $25, is there any rational reason why I would want to buy the least expensive? Why not buy the more expensive drug at that point?
Well, they're identical. In that case, they'd be indifferent because they're paying $25 out of pocket either way.
So here's the interesting thing. The lower the copay, the less the consumer cares about the price. So you can mandate lower and lower copays, but you might actually get the opposite. You might actually drive consumers towards something that's actually more expensive. So for example, under Obamacare, we made birth control have no copay. So there's no copay for birth control, but if you look at the price of birth control as it became free, the demand became enormous or greatly enhanced, and so the prices went up. From 2013 to 2019, you had a 3-fold increase in the price of birth control. So the most important thing is we think things through. We all want lower prices, but if you want to mandate lower co-prices for things, you may well get the opposite because you're taking away the consumer from the equation. Now, the consumer's only involved in drug prices through the copay or the deductible. And so much of healthcare, 80, 90% of it's beyond that. And so how do we lower co-prices or we lower prices for drugs? People hire an intermediary. Dr. Kautzner, does anybody hire you, what, businesses, labor unions, because they want higher prices?
Absolutely not, Senator.
If you didn't provide lower prices, would they hire either another PBM or do it on their own?
So we exist in a highly competitive market. So if we didn't deliver the value that we commit to our clients, they would certainly go elsewhere.
So it's quite confusing. We want to blame PBMs for everything, but why do people hire them? No one's forcing anybody to hire them. So as I understand, the companies represented here represent tens of thousands of businesses who voluntarily come to you and hire you. They pay you and you make a profit. So your profit, is it exorbitant? Is your profit, Ms. Cianfrocco, is your profit greater than the drug company somehow?
Senator, our margin is 4%, roughly 4% for the services we provide to all of our clients.
So that's about like Walmart. I mean, I'm surprised we don't have Walmart here today to beat up on Walmart. We're all unhappy, but we have to be rational about what we're doing. So spread pricing, everybody's like, oh, this terrible spread pricing. Dr. Kautzner, do you offer spread pricing and also pass-through pricing?
Yes, Senator, we offer both options to our clients today. roughly 1/3 choose spread pricing, 2/3 choose a pass-through type of model. They choose spread pricing in order to have predictability on their pharmacy benefits, so we shield them from incremental costs because we effectively provide them with a guarantee or a lock-in on price.
Which is more expensive, spread pricing or pass-through pricing when you offer it?
So we're agnostic to the type of pricing that we offer. It's more for the
No, but when you
client to
offer
make
it,
that
there's a
decision.
price. Is spread pricing cheaper or more expensive than pass-through pricing if I'm a customer?
Generally, they're going to be roughly equal in price or cost.
Ms.
There may be.
Franco, same question.
You're referring to spread pricing as the mechanism where a client pays one price for all the pharmacy claims adjudicated. It offers predictability. In often cases, it offers controlled pricing and can be less expensive than if they pay every claim on a pass-through model, but both are offered to our clients.
This needs to be pretty clear, and people need to think through. We have a bill before us to ban spread pricing. So at least one of the companies, and I think others have said this, spread pricing is less expensive than pass-through pricing. So we're going to ban the cheaper form of buying your drug insurance. Why would we ban the cheaper form? It sounds like if you ban the cheaper form, you might get the opposite result of what you're intending. You might actually get higher prices. Not to mention why we should be banning any of this, but is there a possibility you ban spread pricing and then people decide to add more of a fee on the pass-through pricing? Because, see, their obligation is to their stockholders, and they're legally bound to make a profit. So if you tell them they can't make a profit here, wouldn't they have to try to make a profit somewhere else if they're going to please their stockholders? But the thing is we haven't thought this through. We're angry. Everybody's angry. I'm angry. I've gone to the drugstore before and seen something for $1,600 in acne cream. So we're angry. But why is it so obscure? Why is it different than electronics? Why is it different than buying a car? Why is it different than a lot of expensive things? Because we've made it opaque through all of these different things that we've mandated. In the 1930s, we passed antitrust law, the Robinson-Patman Act, and we made it illegal to pass through discounts based on volume. And then we had a court case in the 90s that says you have to move market share and all these complicated things to get these rebates. But the bottom line is, in a free society, rational thinking, labor unions and businesses and health organizations are choosing a PBM. Why are they choosing a PBM? Do you think they want higher prices? And if a PBM is gouging, then why don't they go to another PBM? There's like 70 some odd PBMs. And yet we've got it in our heads somehow we're going to forbid this. So in the LicenPro example, Dr. Couchner, so what happens to that? If we have a $25 copay and you got $100 Humalog and you got a bigger rebate and you're going to make more profit on the rebate, are you keeping LicenPro off of your list, or can I get LicenPro if I'm a business and I have people who are diabetic in my business?
Thanks for the question, Senator. So our focus is on lowest net cost of the product, and so that's where we're focused the most. And as we all know, all insulins are not created equal. We actually separate insulins into 3 different categories as well. But our focus is lowest net cost to patients.
Let's say they were equal. You had Humalog and LicenPro. It's the same thing. And LicenPro's $100, and you get a $75 rebate to make it $25. So now we're equal price to the business you're selling your plan to, but there is more rebate. Does that mean you're excluding LicenPro from a list that if I'm a business, is it somehow working that way to exclude cheaper generics, is my question.
Our focus is on where lowest net cost is available for products.
So I think there is a possibility, and I think that might be one complaint. There is a possibility of this. However, here's the rub. They are still giving you the lowest net price. And so if you say, well, gosh, the generic, I'd rather have the generic, it's underneath the copay. So it's outside of what the negotiation is. And so that's the only way it's going to make a difference to the consumer. But actually, I think that in the long run, as we look at it, the net cost is still what we're looking at. And so when everybody shakes their head and says, oh, the net cost, the list price mean absolutely nothing, the same way they mean nothing in medicine. But the thing is, we got this complicated thing. This isn't capitalism. We got this because of antitrust laws in the 30s. We got this from a court case based on the antitrust law in the 90s. And we have this complicated system. But instead of trying to unravel the complications we put on the market, what we're asking is to ban certain contracts. So I think what you're going to have in the end is you're going to have the unintended consequences of doing something, trying to make things better, and actually make the situation worse.
Senator Paul, thank you. Senator Baldwin.
Thank you, Mr. Chairman. Thank you to our witnesses today. In preparation for this hearing, I was reflecting back a few years when this very committee had held several hearings on drug prices, and we had panels not totally unlike the one we have today, with representatives from PBMs and representatives from drug companies, and a lot of finger pointing. And I remember a few weeks after those hearings having then Secretary of HHS Alex Azar in front of us, who was formerly associated with a pharmaceutical company as an executive. And I was reading a letter that I got from a constituent. It was a father, two sons, both with juvenile diabetes. And he was talking about just how much the family had to spend each month to keep his sons healthy. And at the end of sharing that letter, I said to Secretary Azar, or asked, what should I tell my constituent about why these costs are so high? And he said, it's complicated. That's what he said. It's complicated. That's not an answer I can provide to my constituents who struggle with this. And there was just a discussion by one of my colleagues about opaqueness and lack of transparency. I find that basically an issue of the industry not being transparent. When I ask questions like, help me follow the dollars, if you double the price of a drug, help me figure out who's pocketing that extra price. And I get, it's complicated as an answer. If we're going to make good policy, we have to have more transparency. And it's why I'm glad this committee is working on measures to achieve that. But one thing I can say when we look at people versus profits is greed is not complicated. Prescription drug manufacturers tell us they invest significant resources in research and development. PBMs tell us they invest significant resources in making drugs more affordable and accessible to patients. But both industries are also working overtime for profits and self-enrichment. Mr. Ricks, yes or no, did Eli Lilly conduct $1.5 billion in stock buybacks in the year 2022?
I believe that's approximately the number.
Mr. Joyner, yes or no, did CVS Health conduct $3.5 billion in stock buybacks in 2022?
Yeah, I'm not sure.
If I had the consolidated statement or consolidated financial statements in front of me that indicated such, would you agree that that's the figure?
I would.
Dr. Kotzner, yes or no, did Express Scripts parent company Cigna conduct $7.6 billion in stock buybacks in 2022?
I believe that that's accurate, Senator. Yes.
Ms. Cianfrocco, yes or no, did United Healthcare, which owns Optum Rx, conduct $7 billion in stock buybacks in the year 2022?
Yes, that's about correct for United Health Group.
Mr. Jorgensen, yes or no, did Novo Nordisk conduct 24 billion in Danish krona, worth roughly $3.6 billion worth of stock buybacks in 2022?
I believe that's approximately correct. We have a majority ownership in the Novo Nordisk Foundation, who gets the money and award money back to society for social and scientific purposes.
And Mr. Hudson, yes or no, did Sanofi conduct 497 million euro of stock buybacks in 2022 or roughly equivalent to $544 million US dollars.
That's correct, Senator.
Thank you. We are taking, Mr. Chair, some steps in the right direction, Mr. Ranking Member, in the legislation that we will be working on tomorrow in this committee. And I am hopeful that we are able to specifically tackle insulin prices later this year. But we can't ignore the business practices of the companies that have come before us today. Part of how we tackle drug prices relates to that need to get transparency and that need to take on the aspect of greed.
Thank you very much, Senator Baldwin. Senator Cassidy.
Yeah, I'll go ahead and take my questions now. I agree with some of what my colleague, Senator Paul, said regarding the adverse, the kind of paradoxical effect of decreasing rebates, but I differ with them on spread pricing. Now, Mr. Kotzner, looking at your testimony, I noticed that you were not as, kind of hesitated when he asked if it's cheaper to do spread pricing versus a fee. Looking in your testimony on page 20, you speak about your pass-through pricing models, and you say clients pay exactly what Express Scripts pays pharmacy for a prescription in this particular model. Clients receive 100% of the drug rebates that the Express Script gets, and clients pay one simple fee. And in this, the pilot program from 500,000 people was a negative 3.5% drug trend, a 12% total medical cost reduction, $193 in savings from closing clinical care gap, and I really like this as a doc who used to take care of uninsured patients, an 86% of patients that were previously non-adherent to their medications improved adherence through your coaching and intervention. That's a good thing. So a negative 3.5% drug spend. So it's pretty clear from your testimony that bannings are not using spread pricing actually decrease costs by 3.5%. But I think it raises the issue of what is actually the spread. Mr. Joyner, can you tell us what, on those contracts with which you have spread pricing, what is a typical spread?
I do not know the average spread per client because it varies based off the performance of the network.
Got it. Mr. Kotzner?
Senator, I don't have the exact amount of where the profitability is.
Ma'am?
Senator, I can't speak to the specific per claim. On some claims, there's a difference by claim. I can tell you we pass through, again, 98% of the discounts, not just from the rebate, but from the spread.
I have limited time. I'm sorry. I don't mean to be rude. Thank you. By the way, I appreciate everything you're doing. I have an article that was sent to me today from first author is Mattingly, Understanding Spread Pricing, How Doctors Flow Through the Pharmaceutical Company for High Utilization Generic Drugs in Medicare Part D. This is Part D. Now, the spread here, Medicare Part D paid an average of $22.50. $3.80 went to the pharmacy, $2.71 went to the wholesaler, $6.73 went for the manufacturer, and 41%, or $9.18, went to the PBM. That was their spread. Now, this is generic drugs and Medicare Part D. It's a pretty good spread. 41% of the Medicare payment for generics is going for spread pricing. Now, I spoke to someone I don't have this in an academic article, but I spoke to someone who has looked at the commercial market, and they have found the average spread is $11.50. Now, I agree with Senator Paul. It should be transparent that someone says, well, wait a second, here we got a 3.5% decrease if we have full pass-through, 3.5% decrease if we just pay a fee. Why don't they just do it? One thing we've been hearing from manufacturers is they have a really hard, from the employee sponsor, they have a really hard time getting this. Now, in y'all's testimony, you say that a third-party auditor can look at this, but that is a third-party auditor for a Fortune 500 company. For the local kind of 200 people employee, they don't have those assets, so I'm told. They're more likely to be fully insured, and the fully insured product is where it's more likely to have spread pricing. I talked to Southern Scripts in Natchitoches, Louisiana, and they charge a fee-based claim with 100% pass-through of everything, and it's $8.50 per paid claim. Now, in Medicare Part D, it is a $9 something spread and with some retention of some percent of the rebates. And here, when it's purely a per fee claim, it's $8.50. So it strikes me, both from your data and from this and from anecdotal data, that the employer is doing better. It's just difficult to figure it out if you're a smaller employer. Now, Mr. Joyner, or one of you, I apologize, in your testimony, you speak about how the average person in a high deductible health plan only pays $18.60 for her prescription. But we know that in a high deductible health plan, you've got an initial deductible of $3,000, let's just pick that number, and then through the course of the year, you have continued drug spend. So what's unclear to me is that when you are paying list price for a drug, not insulin, because apparently you guys have done a good job of some of these drugs, trying to lower it for the person, and I think I spoke to you, Mr. Costner, and you, ma'am, about how you lower it. Hats off, just thank you. But for other drugs, they're paying the full list price when they are in their deductible. It may be $18.60 on the average because through the remainder of the year, they pay a lower price. Have you looked at, and I think I know that 34% of employees nationwide are in high deductible health plans. What is the average cost of a drug when someone, a list price of a drug when someone is in her deductible? Do you all have that data? Because it's $18.60 on the average through the year, but when she's in her deductible, that's where I have a concern. And that's where, if the insurance company knows what her deductible is, and that's what's been negotiated with the plan sponsor, and now she's going to have to pay full freight for that list price because the rebate does not pass to her. The spread pricing is fully operative. She's just paying full freight. Do we have a sense of what that average drug cost is during that period? Mr. Joyner?
I don't have the exact average, but I will say that most of our clients with high deductible plans understand the first dollar coverage and the fact that they want to provide an affordable benefit. So in categories that are attached to the preventative drug list, in many of the cases, the members are paying zero. And then there are many of our customers who choose to pass the discounts through the point of sale, meaning that at the counter, they're getting the discounts.
Do you have a percentage of the customers that would do that relative to the number of patients?
We have over 10 million of our lives in the high deductible plans that are doing that today, so it's a meaningful number.
So 10 million of the 10 million employees who have high deductible plans would get a point of sale rebate?
Exactly.
Okay.
And so on average, our average insulin cost per month
No,
is
but not
$25.
insulin. I'm sorry, that's insulin. I was just talking about
Yeah.
drugs in general.
So on average, the average out-of-pocket expense for our members are less than $9 a month.
Again, I'm talking about specifically.
I understand.
Ms. Cianfrocco, let me ask you on something different. You mentioned the margins being 4%. Is that net of expenses? I assume it is.
Yes, Senator, final margin for roughly 4%.
Now, what I've learned is that there's a lot of vertical integration where there's a GPO, a rebate aggregator, others providing data analytics, et cetera, but they're all vertically integrated within the same insurance company, the same pharmacy benefit manager. So if you pay the GPO a fee for whatever they do, and the rebate aggregator a fee, et cetera, one, they may retain a little bit of it, but on the other hand are you subtracting, is that a business expense and you do not include that in the margin?
Senator, for Optum, our affiliated group purchasing organization does not cost the client anything, and
But is your margin net of that or include that?
our margin is straight margin. It's net of everything.
Senator Kane.
Thank you. To my colleagues, I have some good news for you. In Virginia, there's a company called Civica. It's a nonprofit pharmaceutical company that has taken over a closed pharmaceutical manufacturing company and reopened it as a nonprofit to bring both low prices but also transparency to prescription drugs. Last year, Civica announced that they'll manufacture and distribute affordable insulin products that are interchangeable with the most popular brand names currently on the market, Lantus, Humalog, Novolog. Civica's insulins will be available to consumers at no more than $30 per vial or $55 for 5 pens. No rebates, no opaque discounts, a price everyone can count on. I'm grateful that this innovative nonprofit has stepped in to increase competition in the market, ensure people have access, bring more transparency. And I'd like to ask to my PBM representatives, Mr. Joyner, Mr. Kautzner, and Ms. Cianfrocco, will you commit to offering such low-cost biosimilar insulins as Tier 1 products with $0 or low-cost copays?
We will certainly, we're certainly open to adding any drug that comes with a low net cost and low drug price. What I can't commit to is the benefit design, because that's the decision that our plan sponsors, employers, unions, et cetera, decide.
Dr. Kautzner.
Senator, we actually in 2020 already capped the cost of insulin in partnering with the manufacturers that are here today at no more than $25. We saved patients last year over $18 million with that solution, and now are offering a new flat dollar copay plan design for our plans, which also will cap preferred brands at $25 and specialty generics at just $5.
So it sounds like a no, but I'll go to Ms. Cianfrocco.
Senator, in addition to all the things we've talked about to lower the cost of insulin, I want to be very clear that any insulin offering that's clinically effective can be delivered with support to our patients at scale and is available. List price or net price, as long as it's the lowest cost and it's competitive, it's offered, and it will be offered.
Let me move to my pharmacy execs, and I had a question. I've heard so often from pharma companies that you try to develop a low-cost product that you offer to patients, but the PBMs turn you down. They don't let you have access to the system. And I've heard many in your industry say because they would prefer products with high list prices because they gather fees, and the fees are a percentage of the list price, not of the net price. And that, if I'm right about that, in that sense, to Dr. Paul, the Senator Paul said the list price is meaningless. It's meaningless maybe to a patient. I don't think it's meaningless in the industry, because I think the PBMs collect a percentage of list price even when the negotiated price is much lower. Mr. Hudson, you said something a few minutes ago that perked my ear up. You talked about trying to offer a low-cost insulin product that was, quote, not accepted by the system. That's too opaque for us slow senators to understand exactly what you mean by that. Can you go into more detail what it means that Sanofi had a low-cost insulin that you wanted to provide to more patients, but it was, quote, not accepted by the system?
Yeah, of course, Senator. You know, Lantus has been around over 20 years, and we've tried to bring lower-cost alternatives. Biosimilars have been available, not used in any great detail since 2016. Last year, in August, we launched Lantus, an unbranded Lantus made in the same factory by the same excellent people, with a 60% discount to the list price. It was just not listed on the health plans.
And what was the reason for that?
Well, it's, you know, it's complicated for me to try and be precise, because the conversation will, I'm sure, be between the PBM and the health plan, not between me and the PBM. So we tried to bring a much lower cost Lantus, much lower price Lantus to the table. Of course, there'll be less rebate associated with that.
But when you say it wasn't accepted by the system, well, we've heard there's all kinds of competition among PBMs. You couldn't find any of the major PBMs that would accept this insulin product that had a dramatically lower list price?
That's correct.
Can I ask Mr. Ricks and Mr. Jorgensen, have your companies had similar experiences, whether it's an insulin or something else, of bringing a pharmaceutical at a dramatically lower list price that had capacity to really help people, and to be told that, no, these would not be available on formularies? And if I go to Mr. Ricks first and then Mr. Jorgensen.
Yeah, thanks for the question, Senator. We have, as I mentioned, and I brought 2 boxes of the Humalog product. We make them both. One's called Lispro, one's called Humalog. They're made in the same factory by the same hardworking people. And after 4 years, the Lispro product, which is the copy and now costs $25, is available on about 1 out of 3 formularies in America. So I think it's clear that the lower price is not preferred.
So the PBMs who make the decisions, if it's a higher list price, they like the higher list price better than the lower list price.
That's what the data tells us, based on the market share of the poor performing.
Mr. Jorgensen, how about your company? Have you had a similar experience?
Yes, Senator, we have a similar experience. We have also launched an unbranded version, which is exactly the same product, manufactured the same factories, and it has around 1/3 of the access as the higher list price product has.
And are you told why the lower list price offering is not being accepted on formularies by PBMs you deal with? Mr. Jorgensen?
No, I'm not aware of that specifically. I can say that in general, we keep increasing our rebates, and they go into the PBMs, and obviously I understand they do not decide on the plan designs, but there's this Bermuda Triangle where things get lost. So patients are paying more, we are paying more in rebates, and somehow in the middle there's something that's not really working.
So all three of our pharma company who are here today have had the experience of trying to put drugs with lower list prices out available for patients, but been told they would not be offered on formularies, even so that someone could make a choice. I mean, if something's on a formulary, it doesn't have to be the product that's chosen, but it's not even getting to the formulary. To our PBM witnesses, do you collect fees based on a percentage of the list price of the drug or a percentage of the negotiated actual price of the drug?
Every client contract is different, but we generally either have a fixed fee and or a PMPM, meaning that we've kind of collectively managed the expenses across the population. If I could go back to the
But let me just, though, so you do not have any fee structure in your company where you collect a fee based on a percentage of the list price?
We certainly may have a few in our client base.
Dr. Kotzner, how about you? Do you collect fees based on a percentage of the list prices of drugs that are on the formulary that you manage?
So, Senator, we have a mix of both, where some are a percentage fee, some are a flat fee. But as we've been on the record before, we welcome manufacturers to continue to lower their list prices on all their products, not just on some new products that they're bringing out that are copies of other products. We've been asking for them to do that for years.
Yield back, Mr. Chair.
Senator Collins.
Thank you, Mr. Chairman. In 2018, I chaired a hearing of the Senate Aging Committee on why the cost of insulin was so high. And Mr. Chairman, one of the witnesses was a father from Maine who was going to Canada to get insulin for his 10-year-old son. What we found was a system of getting insulin from the manufacturer to the customer that was rife with perverse incentives, convoluted and opaque. So opaque that the witness that we had, who had done the study on the system, could not fully explain the chart showing all the links. So I want to put up a chart that shows insulin list price, which is the top line, versus net prices from 2012 to 2021. And starting with you, Mr. Ricks, I want to find out where the money is going in that gap between the list price and the net price over 9 years' time. And as you can see, that gap has gotten bigger. You've testified that I think it was 80 cents per dollar doesn't go back to the manufacturer. Mr. Hudson said 84 cents, so similar. So explain to us who gets that money, because I can tell you it's not, for the most part, going to the consumer at the pharmacy counter. Mr. Ricks.
It's a good question. I can explain much better what are the costs that make up the bottom line, because from that's our revenue. We pay our workers, we make the product, we pay to distribute it, and we invest 25% of that line in research and development. The difference are concessions made in price negotiations with large payers like the PBMs here today. I think you'll have to ask them how that gets redistributed in the system.
Mr. Hudson.
That's already a very complete answer. It's the same for Sanofi.
And Mr. Hudson, you would agree that this money does not find its way, in most cases, to the consumer at the pharmacy counter?
I would agree. I mean, over the last decade, the list price has increased over 50%, but the out-of-pocket expense, what somebody's paying at the counter, has increased 45%. So it's, on average, not making its way to the counter for the person who's trying to make a choice between groceries and medicines.
So I think we have a very strange system here, because, to say the least, because most of us would think that the rebate, the discount that is negotiated by the PBMs would largely benefit the consumer at the pharmacy counter. But in fact, it goes to the PBMs themselves, and it goes to the plan sponsors. That could be an insurer, that could be a large employer with an ERISA plan, but it's not making its way down. So the insurers will tell you that, well, we use it to moderate rates, to keep rates lower for everyone. The problem with that explanation is insurance is based on the principle that the healthy are subsidizing the sick. What we're doing is turning this on its head. So in order to lower the premiums for the healthy, we are not passing on the savings to the sick. Mr. Ricks, would you agree with that?
I agree that happens frequently, and I think particularly where Senator Cassidy was going with the high deductible phase in particular, where patients are exposed to full list pricing, there's an enormous difference between what the system pays and what they've paid, and that creates a surplus that's supporting premiums or other things.
So I want to ask our three PBM representatives. Mr. Joyner, who owns your PBM company?
CVS Health.
And isn't there a connection also to Aetna, the large insurer?
That's correct.
And Dr. Kusner, who owns Express Scripts?
Senator, the Cigna Group owns Express Scripts. And if I...
Another large insurer, correct?
Cigna Healthcare, yes.
And Ms. Gianfranco, and I apologize if I mispronounced your name, who owns Optum?
Optum's owned by United Health Group.
And again, another large employer, another large insurer. So to me, this is an example of the system's incentives. If you are, in fact, negotiating for your clients, you're negotiating for your owners, who are all large insurers, for other plan sponsors that are insurance companies, for large self-insured employers, but you're not negotiating for the customer, because it's not, to be fair, it's not up to you what the people who hire you or for whom you work decide to do with that discount. They could pass it all on, but the evidence is overwhelming that they do not. I want to go back to an issue that Senator Kaine raised, and that is the difficulty that biosimilars have in getting onto the market, at getting chosen by a PBM for a formulary. This makes no sense whatsoever to me if you care about lowering prices. So, Mr. Hudson, Senator Kaine talked about the fact that when you come up with biosimilars that are cheaper than your branded product. You can't get chosen. But it's not just you. Even when a competitor comes up with a biosimilar that is way cheaper, and I would use Viatris as an example, which came up with insulin Gargine, which was 65% cheaper than Lantus. It couldn't get on the formulary. So it takes the same product, relaunches it at only 5% lower, and guess what? It gets chosen.
Thank you, Senator Collins. Senator Hickenlooper.
This is one of the most amazing hearings I've heard. It reminds me of a long time ago when I used to be in the restaurant business. I knew a guy, it was probably 30 years ago, had an Italian restaurant, worked very, very, very hard. And, you know, some months he just could barely make things balance. He could not balance the budget at the end. If there was a snowstorm or something, he'd have to go through incredible contortions to stay in business. And he gets frustrated, and he went and he doubled the prices of everything. It was an Italian restaurant, pizza, spaghetti, whatever, he doubled the prices. Within 3 weeks, the number of people coming into his restaurant almost doubled. Same food. He just doubled the prices. That shouldn't be the case. I say that because that's an aberration of capitalism, as Senator Paul would say if he was here for sure. But that's what we're seeing here. We're seeing a case where the higher the price, the more likely a pharmaceutical company can sell their product through the PBM system. So I've got a couple questions. And the 84 cents, so that means that 16 cents stays with the farmers. You're roughly somewhere between 16, 20 cents. You're 16 cents, you're 20 cents, roughly in that range. And I guess we should go down the list of the PBMs and just say, how much of all the rest of that stays with the PBM, right? And then how much is rebates to the plans or to hopefully eventually some of the consumers? Mr. Jordan, why don't we start with you?
So today we pass through more than 98% of all the rebates and discounts to our customers, and 100% in Medicare.
So it goes right straight to the customers.
It goes straight to the customers, which are the employers, unions, governments, et cetera.
Okay, I should have gotten Senator Collins to keep her poster up, because that's a big space up there. For 98% sounds like a big number. That's an awful lot of it going. Doesn't seem like it's going to the consumer who's purchasing it, which is that bottom line, right?
Yeah, I think that's a perfect example of PBM competition. You know, when you saw the price separation, it was at the point in time when we selected one insulin product, and so the result was declining costs for our customers, the payers, while the manufacturer was increasing pricing. So we are passing through 98+% of that value, and the clients are using that to invest, obviously, in their out-of-pocket expense, $0 copays in many respects, and/or trying to deliver the discounts at the point of sale.
Got it. All right, Dr. Kastner?
So, Senator, for our commercial employers, labor groups, health plans, and public sector entities, we pass back over 95% of rebates. I'd also comment on Senator Collins' list price component. That list price continued to go up in the height of extreme competition. Manufacturers are on the record of saying they control list prices. We've been asking them for years to lower their list prices. No one made them increase their list prices. They made that decision on their own.
It seems to me the more they raise their price, just like the Italian restaurant in Boulder, Colorado, their sales go up, which is, you know, anybody put in that position would have a very difficult choice. Yes, Ms. Cianfranco.
98% of the value of the amount of savings that we negotiate gets passed directly to our customer. They do use that for programs like the $0 out-of-pocket that we saw on the life-saving drugs. They do use it, and we always recommend that those dollars are used to protect the patient through things like the high-deductible preventive drug list, which would protect patients for prescription drugs for preventive disease, for life-saving drugs, and chronic disease.
Right. Okay. I'm just going to throw out a fact, because I was puzzled when I went home last night, just because of, as I looked into this, it became more puzzling, but at the same time, somehow almost symbolic of the whole healthcare system, the troubles we have. So, and this is just Googling, so this might be a little bit out of date, but you look at the Fortune 500, the Fortune 100, the Fortune 25, CVS is number 4 in the country. Let's see, United Healthcare is number 5, and Express Scripts, you guys, Cigna, is number 12. So 3 out of the 15 largest corporations in America are all significantly in this integrated vertical spectrum, which somehow finds very puzzling. If you go back and look at the top 20, there are really 8 companies in there that are healthcare related, or 7 for sure. I'm not sure whether you would say Walgreens is more of a retailer or a healthcare company, but the weight there, the preponderance of market mass, it seems inconceivable that these companies could be that large if they're pushing 98% through to their customers, that they would be able to do $6 billion, $7 billion stock buybacks. It doesn't sound like they're losing profitability. Mr. Hudson, at one point you said that, or somewhere had said that you felt that you guys were almost like the canaries in the mine shaft. Is that some reflection of the situation?
Well, what I have said publicly before is that when we used the same insulin as unbranded and reduced the price 60%, we wanted to see whether the system in all its form would pass that on the lower price to patients. And we recently reduced the price again, as you know, 78%. And we have some anxiety that it won't make its way to patients. In fact, patients may be taken off.
So you get, the more you lower the price, the less patients you achieve. So that is the canary at a certain point.
Yeah, that's Chairman Sanders said that this committee may look again in a year to see whether it had impacted access affordability. I think that's the key question. When you bring the price down, remember our net price is $21, which is often less than the copay across all channels. $21 a vial for Lantus. That should change what is available and what patients pay. And if you come back in a year and nothing's changed, in fact, less Lantus is being used, you have to say, system's not working.
That's for sure. Mr. Ricks, let's ask all 3 of the pharmaceutical companies the same question. If you, and you've all lowered your prices, do you think you will have gotten your products, your insulin, to more customers a year from now? Mr. Ricks?
Well, I think it was a risk to lower our prices, but one that we thought was worth taking. We were happy that competitors independently followed that, but we need to make sure that we can have our insulin stay on formularies and available. Hopefully, it would increase availability, but those decisions are in front of us, in front of them.
What's your prediction a year from now when we all have a reunion?
Well, I hope that we'll have better access to low-priced insulin.
Okay, great. Mr. Hudson, what's your sense of that?
Yeah, look, I agree. I think, we spend a lot of time talking about insulin pricing. It's really a net price conversation. It's really what money makes it to make it more affordable for patients. If in a year's time more patients can get access to more affordable insulin, then it was worth doing. I really hope that's the case.
Right. And Mr. Jorgensen, I'm going to assume you're of the same mind.
Yes, I share the same concern. We don't know yet whether we will have access to the patients we have access to today. And I can add that our net price after rebates, fees and discounts today is lower than when we launched the products. So again, if patients are paying more and the price has gone down, something has not worked. Thank you.
Okay, thank you. I'm out of time, but I think we can challenge the PBMs that are here represented, that if you guys are part of the 4th largest, the 5th largest, and the 12th largest companies in this country,
Senator Braun.
we can help resolve this issue.
Senator Braun.
Thank you, Mr. Chairman. I've been wrestling with this issue across the board for at least 15 years prior to coming here. Actually did something about it in my own company across the board too, to make things work for my own employees. That occurred in about 2008. And I was sick and tired of hearing how lucky we were through our insurance companies that it's only going up 5 to 10% per year. And Senator Paul earlier talked about free markets. He and I are going to be in agreement on that mostly, but let me tell you what free markets have in common, unless it's entangled with government like this business is, even more so than most industries. No barriers to entry, robust competition, full transparency, and here's probably the most important one, that the consumer, Senator Paul mentioned this, the consumer has no skin in the game the way it's currently constructed. They either want, when they need remediation, which is a very inelastic demand, when you get critically ill or have a bad accident, they want it done immediately, they don't want to shop around, and they either want their employer to pay for most of it or the government. It's a system by its nature that is about as far from free enterprise. It's more like an unregulated utility, and you're a part of it. The good news is, when I first started looking at it, hospitals were about 30% of the healthcare dollar. Practitioners were about 30 to 35%. Pharma was 15, insurance 15. Insurance and pharma have not changed a lot, even though insurance has become disproportionately more impactful in terms of keeping the whole system glued together the way it is. Sadly, hospitals have grown to almost 45% of the healthcare dollar simply because so many practitioners, that'd be like losing farmers in agriculture, aren't even wanting to get into the business like they used to. Used to be not only the Hippocratic Oath, but they wanted to have their own business to boot. They are increasingly being employed by large corporate hospitals that all play into this lack of what most markets have. So you pile all that up, you're to where Senator Sanders is. People are getting fed up with it. I got fed up with it 15 years ago. The rest of the world can buy drugs for 1/4 the price. They have health care as being 10 to 12% of their GDP, with every developed country having outcomes as good as, if not better. And here we are at 18% of our GDP, and it's going up as opposed to going the other way. Nothing works like that in a true market context. Maybe we'll not get there. Let's look at pharma itself. You've got a proprietary product that takes a long time, investment in R&D. Pointed out that a lot of these drugs have a $5 maybe material cost, yet sell for hundreds of dollars. So it means you've got very low variable costs, very high fixed costs. That's the classic case for how you can charge things and you don't have it related to your actual cost of doing business. Sounds like maybe on PBMs, if that is accurate, that you're working on a 4% profit margin. I assume that's on sales. I'm assuming you're getting a lot better return on equity than that, or else you probably wouldn't be growing your businesses. Something's got to give. You're either going to get what Senator Sanders is proposing, where all other countries have done it, because they've never found a way to address the broad issues I've mentioned, and probably the easiest place that you could fix it would be maybe in primary health care, which never was insurance intended to cover scratches and dents. Never should consumers be in any market where they want someone else to pay 100% of it. Those that can afford it shouldn't even be under insurance for their primary health care. Those that can't should have that support. Otherwise, you never have a real market. I'm going to go to the thing that struck me most kind of significantly was when I heard Senator Sanders ask, why are you selling, especially, I'm sure it's simple molecule drugs as well as the biologics. Why is this stuff selling minimally for 1/4 the price in most other markets that you sell to, and sometimes 1/10? Obviously, you're covering your variable costs. Why are we as Americans paying the bill, even though it is only 15% of our GDP? If it's not working here, how are we going to get the rest of the system to work? Why is that? I never was clear, and I didn't hear a clear answer other than you're going to continue to do it. You want to start, Mr. Ricks?
I can, yeah, thanks for the question. First, one problem with the data that is often cited is list prices in the US, where we get paid on net pricing after negotiation. Those numbers versus Europe are typically about 35% higher in the US than Europe, not double or some other number. So I'll admit they are higher on a net average basis. What do we get for that? We get the earliest access to new medicines of any country in the world. And in general, we have the industry here as well, which I think supports jobs and manufacturing roles, et cetera. So
you're breaking the bank. The thing you got to realize is all the things that you say are attributes of our system, they shouldn't cost us 50% more than what healthcare does across the world. And in your case, since most people have a prescription as maybe their first entry into the healthcare system, here you're showing us where you're charging minimally 4 times as much here, if not 10 times. I don't think politically that is going to get you into the next generations of where you will be like a regulated utility, and it'll be the same format that all other countries have had to go to.
With all due respect, I think we get one other thing, which I wanted to mention, which is the possibility of new cures and treatments. That is funded by more or less the premium we get in the developed world. They fund that for the world. And I think we have to strike a balance between having low-cost medicines today and future
But what does
cures.
that have to do with charging us 10 times to at least 4 times? I mean, why can't they carry? They're the ones not even doing the work. They should be paying more.
I mean, you raise a good point. Lilly will spend about what the entire country of Germany does on pharmaceutical research this year. So why are they not funding that? I don't know.
I think that's something you need to ask yourselves, or else I think the structure of what you're used to is not going to persist into the future because we simply can't afford it. You're in a business that has the peculiarity of uncertain outcomes, R&D, that is bona fide, but I think where you've defaulted maybe somewhere down the line, you say you don't need PBMs. We've had that conversation. Why wouldn't it then, why would you not need PBMs when they are making a smaller margin and it's such a complicated system and you're the producer of the product? In all other industries, you have a wholesaler that buys it, distributes it across the marketplace. And was that 7 minutes, Mr. Sanders?
That's 8 minutes.
Very good. I will yield the floor. We'll have the discussion further. Thank you.
Thank you. Senator Smith.
Thank you, Chair Sanders and Ranking Member Cassidy, and thanks to all of you for being with us here today. I'd like to start with going at how this system affects folks who don't have health insurance. And so my first work in the Senate focused on this when I met my fellow Minnesotan, Nicole Smith-Holt, and heard about her son Alec, who I believe Chair Sanders raised at the beginning, who died of ketoacidosis when he went off his parents' insurance and couldn't afford his insulin. He rationed and he died. Now, HHS analysis tells us that uninsured patients typically pay the most for insulin, and that, of course, leads to rationing. And so we've heard about your patient assistance programs, and you've argued today that insulin is different and better than it was 100 years ago. Diabetic patients need different drugs, need different insulin based on their body and what works best for them. So my first question to the drug companies, can uninsured patients currently access each of your insulin products through all of your patient assistance programs at somewhere between $25 and $35, which I think is the range of prices?
Start? Yes is the answer. If you're insured, it's capped at $35 for every Lilly insulin. If you're uninsured and your income is below $57,000 a year, it's free.
For all, it doesn't, whatever.
Doesn't matter what
matter
insulin you're on.
It's
Yeah,
all of them.
absolutely.
Okay, Mr. Hudson?
The same for us, and in fact, the data is that uninsured patients used that facility over 100,000 times last year for
Okay.
a zero copay.
For all of the insulin
Yes,
products that you
that's
offer,
correct.
not just some
Yeah,
of them?
that's
There's-
correct.
Okay, and Mr. Jorgensen?
Yes, Senator, we also offer a program where people can get access to free insulin and any insulin if they are in a situation where they have to ration. So we are there for all patients with all insulins.
Okay, okay. So what I don't understand is, because I hear about patients being charged list price if they don't have insurance. So I'm having cognitive dissonance trying to understand how this all works. Why don't you just lower the list price for all of those medications and just make it simple? Yeah, or any.
Yeah, we would like to get there, honestly. I think Senator Braun mentioned we'd be happy if there weren't rebates in the system. They don't do anything for us.
So you'd be willing to lower the list price?
We have been, as I mentioned in my comments.
So let me just turn to the PBMs, because the drug companies are saying they would lower list prices. You've been asking for them to lower list prices. Can we just have an agreement today that we're going to lower list prices? You won't charge rebates, they'll lower list prices, and we'd be all done? Who wants to?
I can answer that, Senator. So we've been asking for years for them to lower list prices. Unfortunately, the lower list prices are coming far too late compared to when they could have occurred years ago. Now they're coming because of the Medicaid cap that's going away, and so they're going to be exposed and it would have to pay more. So they're actually doing this because of government intervention, not because they just want to lower the prices. But we welcome them to lower the list prices, and we'd be excited to do so for the value it's going to provide to our patients.
Mr. Joyner? I'll come to.
Similar to Express Scripts, we also would applaud and enjoy the lowering of list drug prices.
And then this gap that Senator Collins showed on her chart, which appears to be the rebates and discounts, that then you would get rid of those.
Yeah, I think there's two things. Because one is that's what the PBM has done to date. So the prices that have been announced on that chart is actually below the cost that they've listed for coverage.
Mr. Hudson?
Yeah, just to be clear, that it was 2018 we brought a lower price analog out, nothing to do with recent policies or announcements, and reduced the price of that 3 times to no effect. And then it was last August that we made in the same factory, as I said earlier, at unbranded Lantus at 60% off, long before this year's debate. So I'm a bit perplexed, because they're there, they have been there, we've stepped up and done that.
Too.
Yeah.
Right. To the PBM executives, what do you say to this critique that your profitability is enhanced or higher when list prices are higher?
So I'll give the Lantus example, because I think it's an important point that's being made, that a lower list price being brought to the market has not been accepted by the PBM. And back in 2017, a biosimilar came to market by the name of Basaglar, which was generic competition in that category. We adopted that product as our preferred product. So we lowered the list price, and we lowered the overall net cost for the customers, and we converted 97% of all the patients on Lantus onto Basaglar. So it was a significant savings for our customers, and we actually embraced a much lower list price than what Lantus was promising at the time.
So this critique that PBMs do better when list prices are higher, does anybody, is that an unfair critique, or how do you see that?
So, Senator, our focus continues to be for our employer clients and patients that we drive to the lowest net cost, regardless of where the list price is. Lantus is an interesting example. So Lantus, when it didn't have competition between 2010 and 2014, actually doubled in price. The price didn't moderate until 2015 and beyond, when competition actually entered the market. Discounts were about 3%. They increased to about 20% in the 2015 range, and then certainly have more than tripled since that point. So just to the questions earlier on products, other products in other countries and how expensive they are, unless there's competition in the market and for us to drive that competition, you're going to continue to see sky-high list prices by drug manufacturers. We're going to do everything we can to bring those prices down, and that may be in the form of rebates, so we can provide discounts back to our employers and our patients.
Well, so let me just follow up on that a little bit with you, if I could. Actually, Senator Braun and I tomorrow we'll be marking up legislation that Senator Braun and I have introduced that would basically be bill that would help bring lower-cost generics to the market more quickly. But of course, that only benefits patients if they have access to them. This is another place where I'm having cognitive dissonance because this brings me to the formularies that, that basically determine what medicines patients can get at what cost. And a recent study showed that in Medicare Part D, a greater proportion of generic drugs are being placed on higher tiers on formularies, which leads to increased patient cost sharing. And another report showed similar trends, forcing patients that actually, so they end up paying more for generics because of where, what tier they are placed in on the formulary. So can you explain, how you see that? What's going on there? Why is that happening? Why does it appear that lower cost generic benefits are not getting passed on to patients like we would have expected and hoped?
So, Senator, we are absolutely supportive of legislation that could help to improve the accessibility to generic drugs, that will remove patent thickets, remove pay for delay, and will provide faster accessibility to more competition in the market. And we welcome anything that can help to do that. On the biosimilar front, we also welcome reducing the patent expiration down from 12 years to 7 years to create more competition, and interchangeability rules as well on biosimilar products so that it's easier for biosimilar manufacturers to come to market and actually be competitive.
Thank you, Mr. Chair.
Okay. Thank you, Senator Smith. Senator Marshall.
Thank you, Mr. Chairman. Ms. Cianfrocco, what percentage of Optum's rebates go back to United Healthcare?
Similarly, we pass along the majority of those rebates, 98%, go to all clients of the...
My question is to United Healthcare. What percentage of all these rebates go back to your parent company, United Healthcare?
Yeah, just like the other 5,000, we pass along the 98%. So United Healthcare is one of 5,000. We pass along 98% of the discounts to the client.
So of all the... we were talking, so Dr. Kreutzner, maybe you can answer the question better. What percentage of your rebates are kicked back to Cigna?
Senator, so we pass back over 95% of rebates to our clients. I don't know the exact number that's passed to Cigna Healthcare.
Okay.
If that's the question.
I think that's exactly what I said. Mr. Joyner, any idea what type percentage your kickbacks go back to Aetna?
Yeah, we don't pass kickbacks back to our company. We do actually pass through 98+% of our rebates to our customers, retaining a little bit more than 1%.
But you won't tell me how much is going to Aetna.
At this point, it goes back to our parent company, CVS Health. It doesn't go to Aetna.
Okay. All right. Mr. Chairman, certainly I think we agree, most everybody up here agrees America's spending too much on prescription drugs. America's spending $600 billion a year on prescription drugs. That's almost what we're spending on the military. And I don't have to tell anybody here, but I want to make sure we understand that Americans spend per capita almost twice of what comparable nations spend. Almost twice what comparable nations spend. Show my next one. I think it's important to separate brand name versus generics, that brand names represent only 8% of prescription drugs dispensed, but 80% of the cost. So 8% of the drugs accounting for 80% of the dollars. Generics account for 92% of prescription drugs dispensed, but only 14% of the cost. So eventually we need to have a conversation about what games are going on with those two types of drugs. Next, I want to talk a little bit about the history of insulin. When I think about insulin today compared to what it was 100 years ago, I think of comparing the single-prop airplane that Amelia Earhart flew across the Atlantic to today's F-35. And I think it's important, again, that we make sure that Americans realize the innovation that's occurred in the industry. Certainly, insulin discovered in 1921, was launched in 1923. Slow-acting insulins were added in the 30s and 40s. We took insulin and added protamine and zinc and made them last longer. Insulin was the first protein to be synthesized in 1963, so figured out the amino acid chain. There's some innovations going on with the gadgets, the insulin pumps, but I want to point out that synthetic insulin was not produced until 1978, that it took the industry 15 years to tease E. coli into making insulin. It was not a simple task, but then it took your industry, some of the players here, another 4 years to bring it to market in 1982, and have to highlight that FDA approved this in only 5 months' time. We go on through the history of this. There's more advancement in technology pumps, and eventually we're able to manipulate the amino acid sequence, and we come up with even new and better insulins, able to more match what we're doing with our own pancreas. So it's been quite a development, and we think we should share the value of what has happened. If you think back to 1921, insulin-dependent diabetes, and that's what I'm talking about today, type 1 insulin-dependent diabetes was a death sentence, life expectancy 1 or 2 years. But once we started squeezing insulin out of the pancreas of animals, people maybe lived 5 or 10 years, but they still were 25 years below the life expectancy of other people in this general population. We continued to 1950, and their 15 years, mortality rate there is 15 years below the general population. In 1978, it's 12 years below the general population, and then today we're sitting at about 7 years below the general population. It's not perfect, but because of these improvements, we've gained a lot of progress. And I just want to stop, Mr. Hudson, what does the future look like for you, just very briefly, as far as innovation opportunities?
Well, I think, and thank you for sharing the journey. I think it's important to realize the contribution that the continued improvement in innovation in insulin has made. The next barrier is really to help patients protect the insulin making function that they have, treat them earlier. You know, we launched Tzield a few months ago, which is to try and stop the progression of the disease, try and halt the disease, try and give young adults a chance to live insulin-free for a number of years, and maybe indefinitely if the trials support that. We don't know, but a life free from needing insulin, a life free from medicines in general, is the ultimate goal. I think we'd all agree with that, a normal life.
Well, thanks. I guess I just want to be careful today. We don't throw the baby out with the bathwater. We certainly think that the prescription drugs are too expensive, but we don't want to get rid of the innovation if at all possible. I want to turn back to the PBMs for a second. Again, $600 billion prescription spend in this country. PBM's gross revenue last year was $500 billion. 84 cents on the dollar goes to the middleman. I think I want America to see what's happened in this industry. I think that this picture paints 1,000 words, that we see the vertical integration that's occurring within this industry. Mr. Hudson, of the dollar being spent on prescription drugs, what amount of that money is going to go to the middleman? You've testified earlier. I just want to get this on record again.
So it's 84 cents of all insulin on the dollar goes to the system or the middleman. On Lanta specifically, it's 93% across all channels.
Okay.
93%.
Mr. Ricks, would you somewhere in that same range?
Similar insulin, it's 80 cents on the dollar for us. For our whole portfolio, which includes newer medicines, it's about 2/3 of all gross pricing goes to the PBMs and insurance companies.
Okay. I think it's been pointed out earlier that these are top 500 companies. CVS is number 4, United Health number 5, Cigna is number 12. Turn to my executives from the PBMs. You all are recently forming some GPOs. Dr. Kushner, where is the location of your GPO? What country?
Senator, it's located in Switzerland.
And Ms. Cianfrocco, where's yours?
It is domestic. It's a Delaware company.
Okay. And Mr. Joyner, where's yours?
It's here in the States as well. It's a Delaware company.
Okay. What is the purpose of the GPOs? Ms. Cianfrocco, what's the purpose of the GPO? And I hope you don't tell me it's to increase purchasing power.
Well, it is a group purchasing organization, so it's designed to allow other companies that negotiate with pharmaceutical manufacturers to increase the counterweight against those high list prices and negotiate additional savings to lower the cost of drugs.
Okay. It feels like it's a shell game to me. That's what it feels like to me, is that we're hiding money here and there. Mr. Joyner, why don't you put some of these lesser expensive insulins on your list of drugs that you can sell, your formulary?
I think, as I mentioned earlier, we have. So in the Lantus example, which is a very high-priced insulin, when the biosimilar
So
was
you're telling me
introduced.
that the pharmaceutical managers the pharmaceutical makers don't get the story right? They all three said that there's certainly drugs that they have for sale that you won't put on your formulary.
If it's not on the formulary, it's because it's not the lowest net cost in the therapeutic class.
Dr. Kirshner, why won't you put some of these on your
Sorry.
formulary? Thank you.
Senator Hassan.
Thank you, Mr. Chair and Ranking Member Cassidy, for the hearing, and I want to thank all of the witnesses for being here today. I want to start by following up on Senator Smith's line of questioning, because I think all of us here would like a world in which your doctor writes you a prescription and you go to your pharmacy and the pharmacy produces the prescription at a predictable price that the drug companies tell us is their price. I mean, that's what I would like, and I would like it to be a low price. And I think every one of us has experienced going to the pharmacy counter and being told by a pharmacist standing in front of a computer, this won't go through, or you're going to need to pay $300. I know your copay for medications is supposed to be $10, but for this one it's $300, and they can't really tell you why. And we all know, you all know, everybody in this room knows, when you've got a child who's sick or a loved one who's sick and you've just been through a process of getting a diagnosis and getting a prescription that you hope is going to help, this is the last complication you need. So Senator Smith was asking about why not just offer, to the pharmaceutical reps here, why not just offer insulin at the price at the pharmacy counter? Eli Lilly, you recently announced, Mr. Ricks, you'd have insulin for $35 or less. Mr. Hudson and Mr. Jorgensen, your companies have said you've made similar commitments. My question is, in your patient assistance plans, how does a patient go about getting this assistance if one of you said it's a $57,000 income threshold? What happens to people who aren't on one of these plans or are uninsured in terms of getting the actual assistance that you say is available to make sure that people don't pay too much for insulin, let's say?
Yeah, I can start. Thanks for the question, Senator. It's important. I think we've all experienced the frustration you
Yeah.
just described. It's why we've worked hard to eliminate it wherever we can. The $35 buy down we have for anyone with a valid insurance card that covers Lilly insulin is automatic in 85% of the cases. The only reason we have 15 that aren't are the pharmacy computer networks aren't plugged in yet, but we're working to close that gap. If someone has no insurance, they have two options. They can go to lilly.com and in literally a few clicks qualify for the coupon and show that at sale, or they can call our phone number and we'll help them.
Okay. Mr. Hudson.
It's exactly the same. If you go to value.com, you can do that. If you go to many of the patient associations' websites, you can get a connection. If you're uninsured, you go, you print it off, you'll get your insulin for free.
So, and when you say you print it off, you print off some sort of coupon or
Coupon,
application?
yeah.
How lengthy is the application process? I mean, what kind of information do people have to provide? You can start, Mr. Hudson.
Yeah, I mean, it's really not that complicated, and it's done, as I said, it was over 100,000 times. It was done for the uninsured, over 600,000 times for people to reduce their copay. It's very straightforward.
I think it's very straightforward for you. I'm not sure it always is for patients. Mr. Ricks, and then I'll get to you, Mr. Jorgensen.
Yeah, in the case of an emergency, which we've heard about, and those are terrible situations that should never occur. I think we all agree on that. If you contact Lilly today, we will ship you a month's supply at no cost with one question: what's your address? You then need to enroll in an annual program if you're below the low-income subsidy level, the $57,000, but that's for the next year. But in an emergency, it's absolutely simple.
And what happens if you're at $58,000?
Yeah, so then you're eligible for the buy down to $35 at the point of sale. And in many cases, people are between insurance plans and it's a short-term need, and $35 is reasonable. Or they can buy our $25 Lispro, which is often purchased without insurance now.
Okay, and Mr. Jorgensen, what's the process like for patients for your company?
It's a similar process, and I don't live in the US, so I actually took the time to go to the US and visit patients and physicians to ask about some of these pain points. And that led to that we enhanced our affordability programs. So it is for a patient without insurance, it is really going to our website, and it's a few clicks, and then you can get access to our insurance at these prices at some $30. Or you can go to Walmart and buy a vial of insulin for $25. That takes no paperwork whatsoever.
Okay, thank you. I want to turn to our representatives from the PBMs now. And this is really following up on a point Senator Kane was trying to make or did make. As we've heard today, manufacturers are taking steps to lower list prices and over-the-counter prices of insulin. However, patients with insurance only benefit from these reduced prices if PBMs also step up to make sure these lower cost options are covered. So Mr. Joyner and Ms. Cianfrocco and Mr. Kotzner, Dr. Kotzner, how are each of your companies ensuring that lower cost insulins, including generics, are available to patients with commercial insurance?
Yeah, it's a very good question, and I would say we start with using competition to negotiate to the lowest net cost. So once we do that, that passes on to our employers and government entities, et cetera, in order to manage the benefit. We encourage them, with the savings that are generated through the rebates and discounts, to actually offer a more affordable benefit, either on a preventative drug list and/or encouraging them to use the discounts at the point of sale. And so 10 million lives, as I mentioned, is already doing the preventative drug list. We have a large number of customers doing the preventative drug list, which is zero. So on average, the actual average cost of insulin is $25 or less. And CVS Health specifically, on our own 200,000 employees, which we want to make the model plan, does pass through the discounts at the point of sale. We also have a preventative drug list so that our employees actually pay zero. So we're very much in alignment.
So, Dr. Kotzner, I'm going to ask you to address the same thing. I'm going to follow up on, I think it was Senator Marshall, to just say we're hearing something different from our pharmaceutical manufacturers here about their ability to list the lowest price drug insulin on your formularies. So why don't you go ahead and address the question?
Thank you, Senator. So back in 2020, we capped the cost of insulin across all the different types of insulins and working with these manufacturers at $25. Last year, it saved our patients $18 million in utilizing that program. We also just recently announced another copay assurance plan. This plan caps not just insulin, but for all employers that adopt it, all other branded products at just $25 that are not specialty drugs. So it keeps it very, very affordable. We also are expanding our preventative drug list as well for those employers that do have high deductible health plans or HSA accounts. I would say having additional options where today medical and pharmacy are combined in the deductible, separating those since pharmacy is the most utilized component of the benefit 11 times a year, and having a separate pharmacy deductible would be another benefit for patients.
Thank you, and I'm sorry we're not going to get to our last witness because my time is up. I do want to follow up with you, Dr. Kotzner, on the relationships you all have with independent pharmacies, especially in rural parts of the country. Thank you.
Thank you, Senator Hassan. Senator Budd.
Thank you, Chairman. Again, thank the panel for being here. Ms. Cianfrocco, in your testimony, you said that PBMs develop formularies for the placement of prescription drugs using clinical foundations. I'd like to understand this a little bit better. As you know, this committee is going to vote on a bill tomorrow that asks PBMs about their rationale for formulary placement. So what do you mean by a clinical foundation for formulary placement, and how does this influence a patient's ability to fill the prescription from their doctor?
Sure. Thank you, Senator, for the question. First, to be clear, our formularies have some of the drugs we've talked about today, which are rebated, but also hundreds of drugs, generic. They're meant to be the lowest cost options for our customers on behalf of their consumers, but it all starts with, to your point, clinical evaluation by an independent committee that evaluates the efficacy of those outcomes of those therapeutics before they can be offered on our formularies.
Okay, thank you. In North Carolina, about 40% of our 10 million residents live in rural areas of the state. And access to pharmacies is critical, especially for those rural patients. I've heard from North Carolinians about rural pharmacy closures and their concern about them. So, Mr. Kautzner, Ms. Cianfrocco, and Mr. Joyner, what steps are your companies taking to make sure that rural Americans have access to pharmacies to fill their prescriptions? We'll start with you, Mr. Joyner.
It's a good question, and I just, as a reminder, the independent pharmacies, especially in the rural markets, are an essential part of our pharmacy network. In many cases, in fact, they represent close to 40% of all the pharmacies in our network today. We do negotiate generally with what I would call a PSAO, or a group purchasing organization. So the independent pharmacies have come together with large wholesalers to actually contract specifically for them. So our contracts with the PSAOs, or with that group purchasing organization, is actually higher than it is for other chain and grocery store pharmacies. So we've actually reimbursed them more, they've actually aligned with large purchasing organizations to improve their purchasing. And again, it's what we believe is an essential part of our pharmacy network.
Thank you for that. Dr. Kautzner?
Thank you for the question, Senator. As a pharmacist and a rural American myself from Missouri, it's extremely important for our organization to ensure that patients do have access regardless of where they live in this country. Unfortunately, today, less than 10% of physicians live in rural America, even though over 20% of the population does. So we're working with independent pharmacies, one, in improving overall reimbursement rates for rural pharmacies on average of 10%. Secondly, we're working with them to do things beyond pharmacy to provide improved access to care of other services, whether those be for diabetes testing, vaccines, doing components around behavioral health testing, opioids. And so those are additional services where they can provide quality of care and be accessible where you don't have to go to your doctor where they may not be. So we're working to enable rural and independent pharmacies so that they can be much more of a health center so patients have access to quality care regardless of what zip code they live in America.
Thank you for that. Ms. Cianfrocco.
The independent pharmacies make up over a third of the Optum Rx network, so they are a critical part and their service is unique. The focus that I'd point to for our community pharmacies is number one, increased sort of reporting, predictability of reimbursement, and reimbursement that that addresses their unique business model, together with revenue enhancement opportunities in areas where they're uniquely qualified, such as medication adherence coaching, disease management, diabetes, and most importantly, identifying barriers to things like rationing and inability to get insulin, because in many cases they are the source of trust and access, and sometimes the only source of trust and access in a rural community.
Thank you. Thank all the witnesses. Chair, I yield back.
Thank you, Senator Budd. Senator Casey.
Thank you, Mr. Chairman. I want to thank you and the ranking member for the hearing. I want to thank all the witnesses for being here. I'm going to be rather brief in light of the time and the vote that's going on. I don't think I have to explain to anyone in this room. I think there's a consensus. When we go back home, we hear from people about the cost of prescription drugs. It's for a lot of families like a heavy bag of rocks on their backs every single day. And we've got to do a lot more. I think both sides of this table have to do a lot more to lower those costs. We're happy the Inflation Reduction Act got those costs down for Medicare Part D beneficiaries. We're happy the companies took actions after that. But my question is, why stop at insulin? So I'm going to ask first on the left side, my left side of the table, starting with you, Mr. Ricks. I want to just in 1 minute, you're being the first one, in 1 minute, itemize for me specific steps that your company is taking right now or will take to lower the cost of prescription drugs more broadly, well beyond insulin.
Yeah, thank you, Senator Casey, for the question, and I totally agree with the sentiment. We need to do more. We're working on a number of things. First of all, we've capped out-of-pocket costs for basically all of Lilly's branded medications on patent medications. Typically, it's around $25 to $35 in the United States. So people with insurance should have a limit at what they pay, no matter how much they use. That's the first step we've already taken. Increasingly, we've talked today about some of the dysfunction in the system whereby lower list price products may not be on someone's formulary, so it's not presented as an option. But I do think I see a future where there'll be more products introduced with two forms, both a high price and a low price. so that those that are in high deductible plans will have a choice that's actually cheaper for them. That's something we can do. The third thing I'd say is we support policies that have a system where there's a beginning and an end to patents and to intellectual property periods. And at the end, competition should flourish. We do support that system. And ultimately, I think a chart was shown earlier about the low-cost generics in America. That's a real success story for American healthcare. We have the cheapest generics in the world, and we support that world. We also support a world where we can afford to invent the product that became generic to begin with. That requires a premium for new products.
Mr. Hudson, if you can just itemize for me, that's...
Sure. Starting with the out-of-pocket commitment as well, in 2022, our copay card was used 2 million times at a cost to us of $850 million. So we're all in on trying to make sure we help. You know, we bookended a rather challenging healthcare system, investing in R&D at one end and trying to help patients make sure they get on drugs at the other end and a black box in the middle. I accept as well that it may be that we have to have high and low price equivalents of the same medicine. In fact, we do now for Lantus. I think it's somewhat disappointing that that has to be the case. I think there has to be a better way where lower prices, lower out-of-pocket, and a reasonable fee, by the way, for a service is provided along the chain. I think it needs some effort. To biosimilars, I think biosimilar penetration in the US lags the rest of the world. And I think, it really should be 60, 70%, mirroring what's happening in Europe and other places. And it isn't, and we have to look to why that is. We bring them forward, but it is not us to choose what goes on a plan. And that's, a broader conversation about how to reduce healthcare costs in the United States.
Mr. Jorgensen?
Yeah, thank you, Senator. So we have the similar programs. So patients who have insurance, they get copay support from us. So they typically pay around $25 in copay. And for patients without insurance, we have patient assistance programs for all our products. And I'll just add that I think we should really focus on what is it the patient pays at the counter. We hear a lot about passing on rebates to clients, but it is really a matter of what the patient pays at the counter that this whole debate should be about.
Mr. Jordan, it's a similar question, but what additional steps can you and the other PBMs take to ensure that patients can afford prescription drug costs?
Well, I'll go back to the original premise that competition works. And so we will continue to look for competition in the therapeutic categories, lowering the cost for the plan sponsors or the employers and unions, et cetera, that actually pay and fund the benefit, and then encouraging them to adopt benefit designs that actually allow it to be more affordable for the members, similar to what we do at CVS, which is a $0 copay for insulin.
Doctor?
Thank you for the question, Senator. We're absolutely focused on continuing to lower costs for our employer plans, our clients, but also for patients. We just introduced a new copay assurance plan, which is flat dollar copays, $5 for generics and specialty generics, $25 for preferred brands, $45 for specialty brands that we are bringing out to our constituents. We are also, through competition, continuing to beat the drum on biosimilar accessibility, interchangeability, and having more access and reducing the patent life for biologics down from 12 years to 7 years to enhance that competition, which will flow through to have additional options in the biologic space. I'd also say there's been a lot of focus here on just price. Care is also a key component of what we do and what we must continue to do. So when patients are on the drugs, they're on the right drugs, and we're able to help them with specialized care models that we have based on specific disease states like multiple sclerosis and diabetes. So you have nurses, physicians, and pharmacists that are trained and can help those patients. Through our program, over 80% of the patients that have specialty conditions are adherent on their medications and can have better health outcomes to live better and healthier lives.
Ms. Gianfranco?
Thank you for the question, Senator. I'll point to three things. The first is a continuing commitment to work for lower drug costs, and that is through a negotiated savings or a list price. We're looking for lowest list prices. We embrace the lower list price. We welcome the lower list prices from the insulin manufacturers, and we request more of it. I'll give you one example. Biosimilar for a highly utilized drug, Humira. New biosimilars have and are coming to market. We're offering up to 3 of those biosimilars at parity with the original product so that patients, their prescribers, and the health plans and clients can select the best option for them. And where the biosimilar manufacturer offered a low list price, we are offering the low list price. Second thing I'll point to is we will continue to recommend and push for benefit designs for our clients that would use the savings that we negotiate and put those to consumer out-of-pocket costs, particularly in the high deductible plans. And the third thing is to Senator Hassan and Senator Smith's comments that no one should be confused at the pharmacy. So additional tools that help consumers navigate their benefit, understand the best options in generic and brand drugs so that they can find the best affordable option for them. That's our commitment.
Thank you, Mr. Chairman.
Thank you, Senator Casey. Senator Mullen?
Thank you, Chairman. I'm just going to make an open comment here. I kind of feel like hell's freezing over because Chairman Sanders and I actually agree on something, and it's that something needs to be done with PBMs. So I do appreciate you having this hearing and the order that we're having it, Chairman. That's actually a compliment coming from my side, if you can believe that. I want to point out this chart behind me. This is the integration chart where it starts showing how PBMs have integrated themselves and they've become their own customer, which is kind of like the fox guarding the hen house. And it's difficult when you start thinking about that Congress was actually wanted to help stand up the PBMs to help bring down cost. You've seen costs do nothing but skyrocket on prescription drugs. At the same time, you've seen that PBMs have become literally $1 billion industry. In the last 5 years alone, you've seen prescription drugs increase by 16%. At the same time, you've seen the net income of PBMs and their integrated companies grow substantially. Start thinking why. I mean, if the $1 billion industry has grown up, it's not because of taxpayer dollars. It's because it's got to be going to the drug cost. And if it's going to the drug cost, who's ultimately paying that price? Well, it's the consumer. Obviously, the money's got to be passed on to someplace. It's just retail politics, and it's retail consumers. The price has to be made up because every one of you guys are in business for profit, and I think that's great. That's called America. We're able to do that. But I want to kind of bring down on some things that maybe need to be clarified. For instance, when Senator Marshall was asking the question of why is it that some drugs aren't able to make it to the market, and I believe it was said that they are if they're the lowest cost. But Mr. Hudson, when that comment was being made, you were shaking your head saying, because what Senator Marshall was asking is what prohibits drugs from coming to the market, especially competitive drugs, because everybody says competitiveness is what brings down the price, and I agree with that. But I don't think you actually agreed with, is it Joyner? With Mr. Joyner's answer when he said it's based on formula, whichever is the cheapest for the consumer. And as I was noticing, just reading your body language, you was going like this. Can you explain more from your perspective what prohibits drugs from coming to the market?
Yeah, I think what I was perhaps reflecting was a lack of unknown. Because, you know, as I said, in 2018, we launched a lower price Admelog, you know, in the insulin market. Last year, a lower price direct equivalent made in the same factory. And, you know, you would expect if price was the answer, and perhaps we talk at slightly different terms, you know, the use of cost versus price, I'm not quite sure what it means on both sides, but I'm reflecting on the fact that if the intent of the chair and everybody here is to lower the price of medicines, and we do, and it doesn't change for patients, I don't know
so
why
you
that is.
you brought a generic to the market, and that was significantly cheaper than the other one, but it didn't reflect the patient's payment?
It just didn't get listed in anywhere. If price is really the motivator, it would
That's
have been
interesting.
listed.
And who prevented that from being listed?
You know, I was not part of that conversation.
But I mean, but the PBMs are the ones that helped bring that to the market, right?
Well, my assumption is
Your assumption?
the PBM.
I think you're being
discusses
very
with the
politically polite here, and I appreciate that. But I think we can all read between the lines on this one. Mr. Ricks, When you're talking about rebate checks, because the comments were made earlier, because the question was asked about rebates, and our PBM officials over here, they were saying that the PBMs go to their customers, which I'm curious of who the customers are, because I think the public would assume that it goes to the public, to the individuals, to the person buying the drugs. But I know I have 6 kids that seem to always be in the emergency room, that always seems to be getting prescription drugs of something, and I've never got a rebate check. So who's the customers? Where do you send your rebate checks to?
Yeah, thanks for the question. We send them to the PBMs, as mentioned.
But where does the check actually get mailed to? Does it get mailed to someplace inside
well,
the United
increasingly,
States?
yeah, we were instructed to send them to the GPO.
Where's the GPO at?
I think it was asked earlier, the various organizations you have up there.
But most of your checks, what country are they mailed to?
Well,
Outside the United States? Or?
There are some that go outside the United States.
And to the tune of how much, would you give me a guess?
Our total rebates in the United States for commercial that was paid to the major 3 last year was $8 billion.
Okay.
It's not a third, but it's roughly that.
And a big chunk of that goes outside the United States?
Several billion.
Goes outside the United States? But yet these are customers for inside the United States?
Yes,
right? These are
correct.
rebates for customers.
U.S., access to U.S. formularies, yes.
But yet the rebate checks aren't actually staying inside the United States, the biggest chunk of them.
Correct, or a big chunk.
That's
yes.
interesting. That's interesting, too. I wonder why that is. And so when we start talking about customers for the PBMs, who are your customers that you're referring to that the rebates go to? Because you say the PBMs only keep 97, 98, or you guys send out 97, 98% of your rebates, right? And the customers is the insurance companies, right?
So Senator, our customers, so Express Scripts has over 2,500 customers. Many of them are employers, small, middle market employers, some large employers. Labor unions are our clients,
So
public sector entities,
or self-insured,
and health plans.
And health plans, right?
Yes,
But also
self-insured, yes.
But also your insurance companies, right? Then the whole reason is to supposedly bring down premiums. But yet, if you look at this top line here where it says insure, the PBMs own the insurance companies that their rebates are going to. It's self-integrated. So you're rebating yourself. That is just, wow, great business model. And we wonder why prices are high to our consumers. And this is why the chairman and I actually agree on something. This isn't working for America. It's working for you all great. I mean, you guys are killing it. But if we're talking about bringing down prices, what have you all done to bring down prices? That was the whole reason why you guys were created, to bring down prices. We've seen nothing but them increase. It's not going to the pharmaceutical companies that are making it. It's not going to the pharmacists unless you own them. But if you own them, we really don't care if it makes it, because upstream or downstream, depending on where they are in the integration chart, that's where you're getting your money back. And you wonder why you're here? Are you actually serving your purpose? Heck no. You're not. And as I said before, it's like the fox guarding the hen house. You've literally forced us to make the changes. And in my private company, if I have an entity that's not being effective for what their intended purpose is, I would shut them down. And that's what I think the solution here is. With that, I yield back.
Thank you, Senator Mullen. Senator Lujan.
Thank you, Mr. Chairman. Thank you, Senator Mullen. I appreciate that line of questioning as well, sir. One thing I wanted to share with everyone as we open up today is one thing I'm very proud of is that New Mexico, as you all may know, recently moved to cap insulin at $25 for a 30-day supply. I think we're seeing more and more attention state to state, clearly here. I appreciate agreements to make insulin more affordable at $35 as well. And I'm hoping that we can find some common ground here to expand upon that. And you know, especially when we talk about folks where this is make it or break it. And for me, that has new meaning. As some of you may know, I survived a stroke about a year ago. If folks don't get their insulin, it'd be like if I didn't have a neurologist or a neurosurgeon. It's a false choice to think you can live without. And there's too many families back home that have shared with me decisions they're making on trying to make that insulin last longer than it should, making decisions about what they're going to buy. And I join my colleagues in saying, whether it's this or in other areas, not in our country. That's just, I don't want to get in the way of innovation. I don't want to stifle research. But when we have something that can transform someone's life and save someone's life, there's got to be a better way for us to make this affordable so that families aren't having to worry about other stuff. And then they have the stress on top of whatever that insulin's going to help with. And I can tell you that stuff doesn't help. Because you could land up in the same situation that I was in. Now, while I'm proud of what we did in New Mexico, as you all know also that the policy left out public plans like ERISA and others. So there's still almost 200,000 people in New Mexico that need insulin that don't get the cap. And that's one of the reasons why I wanted to be here today. And so, Mr. Joyner, what % of appeals for coverage are denied for the insulin prescribed and preferred by a patient's doctor?
I do not have that stat, sir.
Mr. Kautzner, do you have that information?
We can pull that for you, Senator, and get it to you.
I appreciate that, Doctor. Is it Ms. Cienfroco? Did I pronounce that correctly?
Yes, thank you, Senator. Similarly, we can follow up with your office with the exact number.
I appreciate that because in the end here, being able to work with physicians as well and trying to better understand what happens when there's a denial. And I'm hoping we're not going to see high rates here. I won't be surprised if we do. But that's another area where we can do some work and make sure that people are getting what it is that their doctors think that they should get as well. That's another conversation I've been having with people back home. Now, Mr. Ricks, Mr. Hudson, and Mr. Jorgensen, your companies have made recent announcements about reducing list prices to some of your insulin products, and I very much appreciate that. Now, what my team tells me is that according to CDC, about 16.5% of people in the U.S. who use insulin report rationing it because of cost, something I was saying earlier. Mr. Jorgensen, yes or no, can you commit to keeping the price of your current and future insulin prices affordable?
Yes, we have a free option, so people who are in a situation where they have to ration, they can get free insulin from Novo Nordisk. And last year, more than 60,000 Americans got free insulin from our company.
Well, I appreciate that I heard you say yes. That's important to me as we talk about future insulin prices. Mr. Hudson, yes or no, can you commit to keeping the price of your current future insulin prices affordable?
We can commit to that.
Mr. Ricks, I want to ask you the same question, and specifically, should Mounjaro be approved to treat weight loss, will you commit to keeping that drug affordable?
Yes, we will commit to that, and Mounjaro for diabetes today is already a $25 out-of-pocket cap for everyone.
I appreciate that. And lastly, I just want to point out that we know that these reforms work. When there was an effort to cap Medicare Part D, we saw about 9,000 New Mexicans that are going to benefit from saving $443 right off the top. $35 cap here. I'm hoping because of actions that were taken and everyone involved that we can find a way to get there. But Congress is probably going to have to take some action here, and I'm hoping that Congress is willing to do so. So that when we're talking to families, at least that's something that we can all agree on with the work, the research, the investments that are made in these spaces, that we're going to say, yes, we can save people's lives. And when we have these incredible scientists and doctors that are developing these life-saving technologies, that we're doing it in a way that says you're going to get help regardless of how much money you make. You're not going to have to worry about getting that insulin to stay alive. And so I'm certainly hopeful we can get there, Mr. Chairman. I just wanted to come in to just share a few of those stories that we heard from people back home as well. And again, understanding access to care. And like I said, this mattered to me a lot before this last year. But there's been a bit of a revelation to me that when you get sick, when you need help, when you need prescriptions, they should be there for you. Otherwise, you might not get another day to fight for other people. And someone decided that I was going to get another day. So I'm going to be here, I'm going to smile, and I'm going to be nice, but I know how to fight too. And I'm certainly hopeful that we can find a way to get this done together. Thank you, Mr. Chairman.
Thank you, Senator Lujan. Senator Markey.
Thank you, Mr. Chairman, very much. Obviously, representing Massachusetts, I'm very proud of our biomedical research and development, but the challenge remains that much innovation is locked behind walls of research institutions, drug manufacturers, and mazes of pharmacy benefit managers and insurers. And innovation without access is an hallucination for patients across the country. They need access to these life-saving drugs. 1 in 5 Americans with diabetes is forced to ration their insulin. And when patients don't get the insulin they need, they show up in emergency rooms in acute crisis. Patients receiving care from community health centers shouldn't show up in emergency departments. And that's in Massachusetts, and we pride ourselves as the #1 state. You know, we're the brain state. But even we have problems with this issue. In March, both Eli Lilly and Sanofi announced cuts in insulin prices. Some of these forms of insulin have been available since 1996, and prices have only been going up. Now, the price cuts that did occur followed intense public pressure and drug price reform in the Inflation Reduction Act. And if I'm right, it seems that Congress acting was key to actually seeing a reduction in insulin prices that had not occurred in a generation. Mr. Ricks, do you agree with that? That Congress has a role here to play?
Senator Markey, thanks for the question. I agree everyone here has a role to play. In the case of Lilly, we started capping our prices in 2017 and implementing programs including half-price versions of our own best-selling products in 2019. So it's been going on for a while, but I agree everyone can play a role.
Do you agree with that as well, Mr. Hudson?
I think that everybody does have a role to play. Of course, we introduced responsible pricing in 2017, lower cost versions of our most popular insulins 2018, as recently as August last year, an unbranded Lantus made in the same manufacturing center by the same highly qualified people at a much lower price. So I think we're all trying to do our best. I would add, importantly, that we're yet to see whether it makes a difference for patients, whether their out-of-pockets go down, whether their access goes up, whether the lower list price actually has an impact on the choices and their what they pay themselves.
Right, and again, that's just another reason why Congress should act. You know, we to put together some formula that ensures that the benefits flow down to those most in need. And I think that what we're seeing in the last couple of years is that once Congress started to act, it got everyone's attention in the industry. And some of it was voluntary, some of it was coerced, but from my perspective, it did demonstrate the need finally for the Congress to be playing a role because the system is broken fundamentally. And we have to find ways of ensuring that that all of these benefits ultimately flow down to those who are most vulnerable. So, Mr. Jurgensen, do you agree that Congress acting has helped to control the drug prices out in the marketplace?
So, Senator, we, like the peer companies, we have faced declining prices since 2015 we have also tried to launch products with a lower list price. So I agree with you that the complexity of the system creates a flawed system where patients are not getting the benefit. I think we should again really focus on the patient, that what happens at the counter for the patient. If you have insurance and high deductible and you end up paying a list price, that's a big issue. And that's the story I hear from many patients, that in the beginning of the year, they are in a very tough situation. And for those patients, we have already passed on the rebates, so they actually pay manifold more than we as manufacturer got for the product.
So just this week, Eli Lilly announced positive results from phase 3 trials on its own Alzheimer's treatment. And just as insulin for people with diabetes, these drugs could be a lifeline for people diagnosed with Alzheimer's. But comparable drugs on the market cost over $25,000 per year. This is completely out of reach for most Americans, and if the medication is covered by insurance, it will weigh heavily ultimately on taxpayers. Eli Lilly has demonstrated that they can reduce their prices compared with their competitors. They've done it. Obviously, this is a good example that we're talking about here today. Mr. Ricks, will you commit today to offering your Alzheimer's drug at prices lower than your competitors?
Thanks for the question. We're really proud of those results, so I appreciate you highlighting them. We've been working in Alzheimer's for 3 decades and spent over $8 billion on research to get to that point. Today, unfortunately, there's a blockade on Medicare access for Alzheimer's drugs. The first step we need to talk about is how to remove that, because as you would imagine, most people rely on Medicare, rather, who have the condition. I think when you have Medicare coverage, the out-of-pocket cost for patients will naturally be low, and I think the primary issue we want to talk about is how to lift that prohibition from Medicare.
Right, no, I appreciate that. What you're saying on the one hand is, we'd like to help patients, but we have to have the federal taxpayer cover it. And that would ensure that obviously you would get paid. But the question then comes back to you. What can you do to lower the price that then makes it more affordable, separate from a Medicare reimbursement? And I think that's the central issue that we're dealing with here today. It's the excessive, profit taking from a corporate perspective that just leads to catastrophic pricing. And then the off-ramp is, well, we'll just have to have the federal government pick up the tab. And I think that's something that this hearing is intended to finally put a spotlight on in terms of corporations reducing their pricing and maybe having a more reasonable discussion with the federal government with regard to then what is the cost to the federal taxpayer.
If I could, Senator, we will be reasonable in our pricing in the sense that we'll produce value to the healthcare system by delaying the effects of Alzheimer's. But unique to Alzheimer's, Medicare beneficiaries paid into that program their entire life, and they have access to every other type of pharmaceutical for every other condition, but not Alzheimer's right now. I'm just pointing out that flaw in the current system. That needs to change.
And what I'm saying is $25,000 a year is too high. And it's the ask that then goes to the system that then people are then afraid would have an excessively impossible burden for the system to be able to carry. So it then comes back, the ball comes back to you in your court in terms of what you can do to lower that price as you're looking out at this vast number. We have 15 million baby boomers who are going to have Alzheimer's. And that's just for our country. This is a global issue, obviously, and so your market's going to be massive, and $25,000 per year is just too extraordinarily high.
Thank you, Senator Markey. Senator Cassidy wanted to say a few words.
Two quick questions. I felt in my first round I must address spread pricing, but Mr. Joyner, Dr. Kostner, both of y'all spoke of things that your organizations are doing to address some of the market distortions. I want to acknowledge that, both for the rural pharmacies as well as for those people within their deductible. It is a question of how do we get wider spread adoption of some of the things that y'all are doing that would actually address the things that we are frustrated about, that I hear about at church. Like, let me go, let me go, let me go. And I don't know if you have a real quick comment on that. I'll call on you, Dr. Kostner, because, again, I appreciated our conversations. All the things that you've done, is there a way we can get better, faster uptake in the market for that?
Thank you for the question, Senator. So absolutely, we are leading the way on patients having accessibility and affordability with our new copay assurance plan that we've developed. Cigna actually, as an employer, is going to implement it on 9/1 and lead the way for that. We're also asking employers or pharmaceutical manufacturers to help us offset the cost to employers as we bring down the cost of getting to $5 generics, $5 specialty generics, and $25 brands. In terms of our initiative around helping independent pharmacies, we're absolutely working with them in partnership. We've actually created a committee with other independent pharmacies from across America, so owners of pharmacies that will help to inform us so that we can very quickly implement some of the things that I spoke of with Senator Budd. So we're excited to get to work on that and to make some real improvements, especially for rural Americans.
Thank you. Ms. Franco, I don't know this. I know what I'm told, not what I know. I am told that the rebate aggregator is where a lot of money hangs up and is not included in that 98% pass-through that you described. And your answer suggested no, that in the vertical integration of the company, 98% is passed along. I don't know the answer to that. So is the money that hangs up, does money hang up in the rebate aggregator, or no matter where it is in the vertical integration of the company, 98% of a rebate and a fee goes back to the plan sponsor?
Senator, 98% of total discounts go back to the plan sponsor. For our GPO, it does not cost the client anything. So it's for the benefit of the client with no additional cost.
Thank you very much.
Thank you, Senator Cassidy. Let me begin by thanking all of you for being here. I know you had to juggle your schedules, and thank Mr. Jørgensen, who's in Denmark, for being here as well. I think anybody who has listened to this hearing has concluded that the system is broken. It is enormously complicated. There is virtually no transparency. I know that the price that Medicare will pay for a drug is different than what Medicaid will pay, is different than what the VA pays, that hospitals pay a different price, then doctors pay a different price. And all of that opaqueness, lack of transparency, works for both the drug companies and I think the PBMs as well. So the end result is we have got to conclude that there is an enormous amount of greed going on, and different members have touched on this. Let's not be naive. The drug companies, major drug companies last year made $100 billion in profit. PBMs made $27 billion in profit. Drug companies tell us, well, we need that money. It goes into research and development. Well, guess what? More money went into stock buybacks, significantly more, than went into research and development. So Wall Street and your investors are making huge amounts of money while ordinary Americans are going bankrupt trying to afford the drugs that you sell. And I got a real concern that many of the new drugs that are coming out are outrageously expensive. In fact, nearly half of all new drugs coming to the market are over $150,000. I don't know how somebody who has cancer pays $150,000 for a drug. And by the way, I talked to a leading oncologist who told me that in some cases, it costs a few bucks to manufacture those drugs. All right, let me just conclude by saying this committee is going to stay on this issue. We need profound change in the industry and in PBMs. Tomorrow we're having a markup on a very modest set of bills. We are going to come back. And when you go to sleep tonight, I hope you ask yourselves, think about the people who died because they can't afford medicine. Think about the millions of people, even not in the United States, who cannot afford the products that you make that cost you a few bucks. I, for the life of me, just don't understand how when you have something that saves a life and it costs you a few bucks to manufacture and you're already making huge amounts of profits, why we can't make that product available to all at a price that they can afford. That is a moral issue. So we got a lot of work to do, but we clearly need revolutionary changes in the way we do prescription drugs in this country, and that is tied into the fact that some of the Republican senators have made. We're spending twice as much per capita on health care in this country. Drug prices are an important part of that. People can't afford health care as well. So once again, we look forward to continue to work with you. I thank you all very much for being here. And this is the end of our hearing today. For any senators who wish to ask additional questions, questions for the record will be due in 10 business days on May 24th at 5 p.m. Finally, I ask unanimous consent to enter the record one statement from stakeholder groups outlining their views about insulin access and the prescription drug affordability crisis. The committee stands adjourned. Thank you all very much.